Okay, those of you joining us remotely, please be aware I do not have an assistant today. So when you put your comments in, it may take me a little bit of time to get to them. So kind of keep that in mind. You won't get immediate feedback, but I will get to your questions. All right, good morning, guys. Have you ever had a Wednesday that feels like a Monday? It's what I'm having today. All right. Anybody have any questions on chapter 4? Any questions on chapter 4? No? We're good? Good morning. All right, I'm going to go ahead and get your scores for chapter 4. Dina? Ashley? 15 out of 20. Okay, thank you. Abby? 20 out of 20. Thank you. Caitlin? 20 out of 20. Thanks. Carsey? Thank you. Pilar? Thank you. Michelle? 100. Thank you. Lisa? 20 out of 20. Okay, thank you. All right, let me just go back through here. Abby, do you have chapters 2 and 3 for me? Both 100's good. Very good. Caitlin, do you have 1, 2, and 3 for me? Yes, they're all 100. Thank you. And Pilar, do you have chapter 1? Thank you. Okay. All right. So we read chapter 4. Let me just take this down. Let's see here. Oh, let's put this comment up here. I was able to pass my test watching your videos. Thank you so much. Congratulations to you. Great job. We're super proud. Okay. Let me just take the banner down here. Oops. Okay, there we go. Now you guys can see. I used to do this all by myself with no assistant for like over a year. Now I'm spoiled. So I'm going to have to work out a new workflow. So this was what chapter 4 was all about, the 10 body systems. And I feel like chapter 4 is kind of needlessly complex. CNAs don't need to go into a lot of detail with body systems. If you go on for nursing, you're going to have an entire year of anatomy and physiology. So you're going to go into body systems way down to the cellular level. So you're going to have a lot of this in nursing, those of you that go on. But as a CNA, we don't make decisions. We don't plan care. We don't put 2 and 2 together. So I feel like chapter 4 really is very complex. That is not really in line with your role, your scope of practice. However, there are some things in chapter 4 that we do need to know. So I want to try to help you sort through everything that you read and really focus in on the things that matter to you and your role. So that's what we're going to do this morning, is review the body systems with a special emphasis on the changes of aging for each body system. So the nervous system, made up of the brain, spinal cord, and nerves. This gives you all of your senses. And this is kind of the master of the universe. If your nervous system isn't working well, nothing else is going to work well either. Primarily because everything involves the nervous system to work properly. Like your heart isn't going to beat appropriately if the signal that tells your heart to beat is a little wonky. Make sense? So this is the master control system of everything. We are most aware of the nervous system through our 5 senses: taste, smell, sight, sound, touch. Those are your five senses. And that's where you're going to see the most signs of aging is in those five senses. So reflexes are going to slow down. If you go, I did this the other day. I made a loaf of banana bread and I pulled it out of my oven with pot holders because my brain knew it's in the oven, it's hot, I need pot holders. Well, after about 5 minutes, I went and did something else. I come back and I went to tip it upside down onto a plate so it would cool. My brain totally forgot that came out of the oven and it is hot. So I grabbed it with my hands, and as soon as I felt hot, I let it go because my reflexes are still good. If my reflexes were not good and I did not let go of that, what would have happened? Would have burned me. I probably would have blistered. So this whole reflex system slows down. Like my hands knew, hey, this is hot, but it takes time to get that signal to the brain. When you're younger, the signal travels super quick, speed of light. When you get older, there's a lot more roadblocks in the way. So it takes longer for that signal to go through. So reflexes are going to be affected. That means that your patient is more at risk for injury. If you're walking and there's just a little change in the height, like 1 foot is on carpet, 1 foot is on tile, you guys will accommodate with that just fine because your nervous system, your reflexes can adjust your balance. When you get older, that reflex can be affected. So uneven surfaces can actually increase the risk of falls. This is why we don't like a lot of throw rugs laying around, uneven surfaces. They also provide a tripping hazard as well. So throw rugs just aren't good in general. But diminished reflexes is going to be a really big risk factor for your patients. And this is, we don't want to hand somebody a super hot cup of coffee because they may not, if it spills, they may not have the reflexes to stop more from spilling. You get decreased coordination. Memory impairment can happen. And decreased concentration. I'm really having a problem with this one right now. Decreased concentration I am struggling with because I've got like a million tabs open up here and my brain is just, going back and forth with all these tabs. And, I'm just not able to focus on any one thing because I got too much going on in my brain. That can happen as we age too, because there's so many things that your brain has to pay attention to. Make sense? We have a lot more risk factors, a lot more things to be aware of and try to avoid. So you end up with your focus is split. But I want to specifically go back to these senses because this is really where CNAs are going to intervene. This is what's going to affect us the most. As we age, eyesight tends to diminish. Where you might be able to read something on your phone now, when you're 80, you may not be able to read that same thing because the eyesight is diminished. Well, not too many 80-year-olds are running around with cell phones, so that's not really much of an issue, is it? But what are some other things that they might need to read? Messages, email, contracts, right? Greeting cards for their birthday or anniversary. There's a lot of things that patients may need to read that they just can't any longer. We can help them with that, except for the contracts. Why don't you think that CNAs can help them with contracts? Private, that's one of the things. It's also legal. It's a legal thing. So if we have somebody that we've been helping them read their greeting cards and letters from their, family and things like that, and then they say, oh, I've got this contract, I need you to read this out loud to me. We have to then say, I'm sorry, that's the one thing I can't help you with. Let me go get your nurse. And they'll get a social worker or a legal advocate or somebody to come in and help the patient with that. Make sense? Because it's real easy to slip from, let me read this to you, to them going, well, what does that mean? Real easy to slip into that. Make sense? Hearing, often affected as we age, often affected. So one of the ways that CNAs generally help patients that are hard of hearing, have a hearing deficit, is we tend to shout really loud, and that does not help. Does not help. When we shout, our voice goes up an octave. It raises in pitch. Make sense? Higher pitches are what they're going to have trouble hearing. So even though your volume might be louder, your pitch is higher, and they're not going to be able to understand what you're saying. Much better to get a little closer and lower the tone of your voice. Talk way down here. And when you lower the tone of your voice, they're much more likely to be able to register that. So yelling at someone that's hard of hearing doesn't generally help. Get closer. Talk in a lower pitch. You can still raise the volume and project, but you want to stay in that lower pitch.
One thing I notice is when people, because I work on people, I can hear and it does its job, but it's not 100%. And people will sometimes talk to me and they walk away.
Oh, yes. You have to face the person.
That's just one thing I see all the time, even with me. Like people will talk to you, sometimes they walk away, and I'm like, I miss that.
Absolutely. Absolutely. So you do have to face somebody. And this kind of goes along with the sight too, that I forgot to tell you, is that when you're younger, you can get away with lower lighting. As we age, we have to have better lighting. And a lot of times CNAs, I've seen this before. I don't know what the mindset is here, but a lot of times CNAs think, well, if you're visually impaired, we'll just leave the light off because you can't see anyway, I guess. But that's actually the opposite of what we want to do. If somebody's having some visual problems, we want brighter light. We want everything well lit so that we can capitalize on the level of ability they still have. Does that make sense? So this kind of goes along with facing somebody when you're speaking to them. I often watch faces for verbal cues when you're talking to me. And I can pick up things by watching how you're saying something that I might have missed verbally. So that's a very important point, is to make sure that you're facing somebody when you're talking to them. So sight and sound, those are two things that we're pretty familiar with as far as aging goes. But let's talk about taste, because taste is affected as we age. Things that we absolutely loved, our very favorite meals when we were younger, may not hold any appeal to us anymore. Older patients may not get excited about meal times, and they may not eat very well. You pair that with swallowing difficulties and gastric emptying problems, and all these other things that go along with aging, and mealtime can actually become a struggle. So we want to make meals as enjoyable as possible. Don't rush them. Make sure the food looks appetizing and smells appetizing. Those are things that we don't really think about when it comes to the brain, spinal cord, and nerves, is how it's going to affect your patient's ability to eat. All right. Then we have the cardiovascular system. Now, this is the heart. Blood vessels, arteries take blood away from the heart. Veins bring blood back to the heart. It's kind of a one system, but does two jobs. And as we age, this system tends to break down a little bit. It doesn't work as efficiently, which means our heart can beat harder with even just a little bit of effort. Where you might have been able to run a 5K when you were younger, now 5 steps might be an issue because your endurance has been affected. higher blood pressures. We're going to talk about that a little bit later on in the program. Prolonged bleeding occurs, and veins become very, very fragile. Now, what that means is even the slightest bump can cause bleeding under the skin. And you can actually see that here, right? Even the slightest little bump, just hitting something a little bit. So when we're working with older individuals, we have to understand, we talked about the lack of fat under the skin and how that can affect temperature regulation. But we also have to understand that there's nothing cushioning those veins now and those capillaries. There's no cushion there. So when we're working with older patients, we need to be very aware of this and be really, really gentle with how we're working with them. Does that make sense? I just saw a thing this morning on one of the Facebook groups. This male caregiver, I don't know if he was a CNA or a caregiver at assisted living or whatever, was basically trying to get a patient up or a resident up off of a couch and was extremely rough with her. This, little teeny tiny little old lady. And all I could think of is, oh man, she is going to be bruised. She is going to have so many bruises on her. Oh, absolutely. Tear the skin. But, again, how do you think that she feels with somebody being that rough with her? Not very happy, scared. I'd be scared because you're vulnerable. I'd be scared. And when I'm scared, I generally tend to get defensive because I'm scared, right? And yeah, I'm going to tense up. Absolutely. Absolutely. So we have to understand that this, the breakdown of the cardiovascular system is going to make working with the patients require even more gentleness. Then we have the respiratory system, and these two kind of go hand in hand. These are kind of like twins. I always look at them like twins. We've got the cardiovascular system that pushes blood around the body, but that doesn't do us any good if we don't have oxygen in the blood. Okay. So the lungs is what's going to put the oxygen in the blood. The heart is what's going to push that oxygenated blood around the body. You have to have both of them working. One working without the other has no benefit to the patient at all. So I kind of look at these as the dynamic twins. You have to have both of them to work. Unfortunately, as we age, this system is affected. We end up with decreased volume, which means it's harder to get a deep breath. It's just, your muscles and your diaphragm, they just don't work as well as they used to. So if you're not able to get a deep breath and our heart is a little bit tired, that means we're going to be out of breath doing the most simple of activities. Putting your socks on becomes a major challenge of your day, right? Things you wouldn't even think twice about. You put your feet up on your knee and you put your socks on and your shoes on. You don't even think about it. But as you age, this becomes a big deal because you don't have as much oxygen available to you. Shortness of breath, very common. Just getting a patient up to the bathroom can cause them to be huffing and puffing. And this is a very common sign of aging. Endocrine system, this is a system that's kind of not real well known. I always think of this as like the middle child, right? Everybody pays attention to the older and the younger, but the middle one kind of gets overlooked. Endocrine system is the middle child of the body systems. But it's one of the most important because this sends all the chemical messengers that tells every other system what to do. So it's hormones. Now, we all think about hormones. We think about middle school hormones. Those aren't the only hormones of your body. You have pituitary hormones. You've got thyroid hormones. You've got digestion hormones like insulin. You've got hormones that affect your blood pressure, your hydration balance. There's the hormones in your body regulate all processes, everything. everything your body does is regulated by a hormone of some sort. Well, if this system starts to break down, all of those things are going to start to break down a little bit. So we can end up with sleep disruptions, decreased bone density, a reduced metabolic rate, which means that we don't burn our food as quickly. We stay fuller longer. And you really are going to have to encourage your older patients to eat. But let's talk about sleep disruptions, because this is probably the number one complaint of CNAs that work the night shift. They expect their patients to go to bed and stay there. Well, older patients don't have the same sleep patterns that you do when you're younger. You'll go to sleep, in the evening, whatever time you go to bed, and you'll probably sleep pretty much straight through for 6 or 8 hours, sometimes 10 or 12 hours. That doesn't happen when you're older. 2 or 3 hours, they may be up again and not able to sleep. Well, don't get mad at them. Don't force them to stay in bed. That's not our role. We have to understand that sleep disruptions, very, very common with aging. Urinary system, we've talked a little bit about this one. Bladder volume decreases. They cannot hold as much. The valve at the bottom of the bladder gets a little floppier, so they're not going to be able to hold it as long. So that means more bathroom trips and quicker bathroom responses. Make sense? So urinary system is definitely going to be affected. Women tend to get more urinary incontinence, especially when they sneeze or laugh or try to lift something heavy or jump up and down. Female urinary incontinence is actually somewhat common in aging, especially if the female has given birth, because that weakened the pelvic floor. With males, they don't have as much incontinence due to stress, what we call stress, coughing, sneezing, laughing, lifting. Males tend to get the other side of this, where they have difficulty going because their prostate enlarges. It's a sign of aging, a normal thing, and it puts pressure on the urethra, the tube that the urine goes through. So women tend to have problems going all the time, and men seem to have the problem of not being able to go very often or not being able to completely eliminate. So again, both of these are going to require frequent bathroom trips. Somebody said one time, 75% of being a CNA is toileting. 75% of being a CNA is toileting. And I kind of agree with that, because when we understand how this works, we understand that we're going to be in the bathroom with our patients a lot. And if they have decreased coordination and an increased susceptibility of injury, we're going to have to help them with that. So toileting is a very big part of what CNAs do. Skin system. This is the most visible sign of aging. This is the most visible sign of aging. We can see this happen. You can't see the changes in the endocrine system. You can't see the changes in the urinary system. Those are all buried in your body. But you can see this. We end up with thinner, drier skin that tears easily. We end up with less pigment in our hair, so it turns gray or white, unless you dye it like I do. We end up with wrinkles or the folds in the skin because we lose the collagen that holds that skin firm in place. We end up with brittle nails, and that's going to affect how we do hand and nail care. Make sense? Good? You can also get darker pigmented age spots. I always find this funny because as you age, it's like your body tends to rewire itself. It's kind of funny. It stops putting pigment here and puts it here instead. Did you take a wrong turn? Let's put it back in my hair, right? So you like all of the pigment of your body just like all of a sudden changes places. You stop getting pigment where you used to, and you start getting pigment in other places. And it's funny. And a lot of your patients will be very, very absorbed in this because it's visible to them. So helping your patients feel their best is an important part of what we do because they know that right now they don't feel like they look their best. Does that make sense? Reproductive, this kind of goes without saying, the reproductive system is affected by aging. We end up with decreased fertility, of course. Skin can become thinner, drier, prone to irritation. Erectile dysfunction can occur, decreased moisture production. But the one that affects us as CNAs the most is this one, hot flashes and night sweats. Your patients might have hot flashes or disruptions in their body chemistry. And they may have been super cold. You had a sweater on them. They're sitting in the hallway and all of a sudden they're just trying to take stuff off because of this hot flash. Don't yell at them. Don't make them feel bad. I just put that sweater on you. You said you were cold and now you're taking it off. What are you trying to do? Make me crazy? Their body is what's causing them to do this. They're not trying to make things difficult on you. Make sense? Good. Night sweat's very common, and this is why we often have to change the sheets in the morning, because if they've sweat through the sheets during the night, we want to make sure they have clean sheets on the bed. Gastrointestinal system. This is the one that's probably going to be the most concerning for you outside of toileting, because eating is a big part of what we do, helping patients with eating. So we need to understand digestion is going to slow down. And in fact, how many of you guys eat your biggest meal at night for dinner or supper? Most people do. That's our society. It's our culture. We tend to eat the bigger meal in the evening. Well, as we age, that becomes problematic. Because if you're eating your biggest meal in the evening and we have slowed digestion and then we go lay down in bed, all of that food that's still in the stomach can start to come up into the esophagus, and we can get heartburn, and you can actually get GERD or gastroesophageal reflux disease, where all that acid comes up into the esophagus. And that sounds very boring, very benign, but we have to understand this is acid. What does acid do to tissues? Yeah, it burns. Absolutely. So we're actually inside the body burning the esophagus, and that can have long-term effects. Esophagus muscle tone diminishes. This is your swallowing tube. So if we don't have good swallowing reflexes, that can be difficult because now the patient can start to choke on their own spit. Constipation, very, very common. Your patients are very concerned about their bowel status. This will take up half of their day, being very concerned about their bowel status. They're not going to absorb as many nutrients, and their hunger and thirst reflexes diminish. But let's talk about the thirst. We've already talked about hunger. Let's talk about thirst. A lot of times with your older patients, they are not going to get thirsty the way you do. They just aren't. That reflex diminishes. Now, in Florida, here, we have a lot of humidity. And we keep most of our older patients in an air-conditioned environment for temperature regulation and comfort. Air conditioning dehydrates. That's how it works. Air conditioning takes moisture out of the air to cool it down. That is exactly how air conditioners work. So if we have a patient who is in an inside area that's air conditioned and they don't have good thirst reflexes, what might they be at risk of developing? Dehydration. And an estimate is about 80% of all older people are dehydrated, chronically dehydrated. So if they get an illness that further dehydrates them, that can be the difference between surviving the illness and not. So we often encourage patients to drink. Every time I walk into an older patient's room, I am encouraging them. Hey, Mary, did you drink your water today? I see that cup is still half full. Why don't you take a drink for me? Because they may not have that prompting in themselves. Good? Make sense? A lot of CNAs don't do this because water in equals water out. Remember, about 75% of our job is toileting, right? You don't want to be doing that. So if you don't encourage water, they don't have to pee as much, frees up your time. That's the wrong way to look at this. Good? Chronic dehydration, that kills so many patients. Dehydration kills. Musculoskeletal, this kind of goes without saying. Bone density decreases, your muscles get weaker. You tend to have coordination issues, inflammation of the joints. Man, I've got that. Ooh, pain and stiffness. This is bad. I did not understand just how bad that hurt until I got it. And I've got really bad arthritis in my knees. And you'll see me when I go to take a step and I just kind of stop real quick. That's because it is like a 9 out of 10 pain when that bone on bone pain hits. That hurts. I didn't know that. When I was younger, I'm like, arthritis, no big deal. Woo, man, was I in for a rude awakening. Big deal, guys, big deal. And instability and coordination impairments, that occurs too. Lymphatic, this is a system nobody really knows much about. It's just kind of a last chapter in the back of the book. We don't really care about it. We don't know much about this. But the lymph system has to do with your immune system and fluid balance. And it's very, very important. We all know that when you get sick, you get some swollen lymph nodes in your neck, right? So we know that lymph nodes have something to do with disease process, sickness and illness and things like that. But it has way more jobs to do than that. Way more jobs. I'm not going to get into the lymph system too much. If you take anatomy and physiology, you will spend an entire 6 weeks on the lymph system. It is that important. That important. But the biggest thing that I want you to understand is when our lymph system does not work well, we do not have good immunity. We aren't able to fight infections as efficiently. And we also end up with retention of fluid, particularly in the legs, because when fluid goes down, the heart pumps, blood goes down to your toes because your toes need blood. That blood has to come back up to the heart and it's got to fight gravity. Well, fluid doesn't fight gravity real well. So if the fluid can't get from the toes back up to the heart, it's going to stay in the legs. It just can't make that return trip. So when we have fluid that stays in the legs, we get swelling. And that's going to be very, very common with your older individuals. So putting the feet up above the level of the heart allows that fluid to use gravity to come back up from the legs. Putting their legs like this does not fight gravity. We need those legs above the level of the heart. So when you have a patient that has an order to put their legs up in the afternoon, that's what it means, legs above the heart. So lay them in bed, put some pillows under those heels, let them take a little break. Don't skip it. All right. Any questions on the body systems? Questions on body systems? Okay. Let me just check comments here real quick. Good morning. Okay. Good morning, everybody. Thank you so much. Okay. So we learned a few skills. Where's my drink? We learned a few skills. The first skill we learned was pulse. And in order to take a pulse, we want to use 2 fingers, not our thumb. Pulse is going to be located at the top of the thumb side of the wrist, way up here at the bendy part, not way down here, at the lines, at the bendy part, like right where the thumb starts. Normal is between 60 and 100. If we get anything else, we tell the nurse. For the test, you're going to count with 2 evaluators. And you're going to have to say start when you start counting and stop when you stop counting. Good? Questions? This is a documentation skill, so you have to document. Did anybody ever see the new video I just put out on Pulse? If you go to my YouTube channel and you watch my new Pulse video, the way I did this is it allows you to count the pulse with me on the screen. So you'll see me do this whole skill, but the way that I did it, it's pretty, because remember with Pulse, we're not hearing anything, we're feeling something. So how can I show you what I'm feeling without making it audible, right? So I had to come up with a very unique way of doing this. So if you go watch the video, you'll be able to count along with me, see how close you get. And when I document, you can double check your reading. Okay, good. We also learned how to dress a resident with a weak arm. So this person has a weak arm. We're going to ask about clothing preferences. We're going to undress the strong arm first and dress the weak arm first. And we're going to minimize exposure as much as possible. That means we'll get the clothing before we undress them. We'll use a privacy blanket and make sure that the curtain is closed. We're going to lift all extremities from below with a flat palm. You want to don't overextend or force movement. Make sure that you're being gentle when you lift. Make sure they look good at the end, so you'll adjust the clothing for neatness and appearance. We'll put our dirty items in the hamper, and the call light goes in the stronger hand. We learned how to do hand and nail care. So for the test, we only have to wash one hand because our care plan said to wash one hand, and that's all we're going to do, what the care plan said. So we're going to support the arm and wrist at all times. Make sure that the hand is on a towel if it's not in the basin. You want to, kind of cushion it a little bit. You're going to wash, rinse, and dry that hand. We'll clean under the nails with an orange stick, file the rough edges with an emery board, apply lotion, and wipe off the excess, and then clean up. We learned how to make an occupied bed. We'll make sure our patient is on their side in the middle of the bed. We'll change the bottom sheet first using clean rolls toward me, dirty rolls away. Once we have that bottom sheet changed out, we'll change the top sheet. Then we'll change the pillowcase. Keep the patient in the center of the bed at all times and make sure that everything is nice and neat when you're done. The corners of the sheet should not touch the floor. They should be underneath the mattress. So hospital corners don't have to be perfect. And the pillowcase should always face away from the door. And that's just because we don't want pathogens to come inside the pillowcase where the patient can breathe them in. We learned how to do range of motion. In fact, we've learned 2 range of motions. We're going to lift extremities from below with a flat palm. 2 points of support near the joints. We'll move slowly and smoothly. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. We just follow the recipe. So we've covered a lot of information, a lot of stuff. Now we're going to move on to some new skills. The first one we're going to learn today is side lying position. So if you turn to page 138 in your book, if you look down here, it's showing you all the principles involved in this skill, and they're all spelled out here for you as well. I have a video for this. Down here is your testing information. Somebody with your level of experience should be able to turn somebody on their side and put some pillows in place in 8 minutes or less. That's all we're doing here. It's going to be a live testing student, so one of you guys might be the patient for this. That person will be positioned in bed at the beginning of the skill. Charting is not required. So this is the principle that we have to learn for this particular skill, scoot and roll. And we did talk a little bit about this on Monday. So we're going to expand on this a little bit. Page 139 has our care plan at the top of the page. It tells us to position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. I have step-by-step instructions down here. I want to point something out to you. This somebody just asked me this, and I want to go over this with you. When you're reading this, these step-by-step instructions, off to the side, there's a little number in brackets. Somebody says, what is that number? So let me explain to you what that number is. Do you guys remember this? Do you guys remember this? Those are our testing care plan sets. On the back are the checkpoints you're going to be graded on. Each checkpoint has a number. So this step right here, place soiled bath blanket and dirty linen, has a 13 beside it. So if I go to supported side lying, look at 13, it'll tell me what checkpoint that step is checking off. Okay, good. Make sense? So that's what those numbers mean. If it has a number, it means it's being checked off by something on the test. So a question I get asked a lot is, well, how many steps can you miss and still pass? Well, if it has a number on it, you probably shouldn't miss it. It's important. But I've got one person on our channel right now that is preparing to test, and she's very anxious, and she's asking a lot of questions. And I don't think that she's got a good instructor that she can go to ask these questions, and I'm trying to answer them as best I can. But one of the things that she's very concerned about is, and she's got the checklist, which is good. She's looking at that checklist to see what she's going to be graded on. But she's very concerned about, well, what if I miss this step? And my comments are all full of, what if I miss this step? And the answer to that is, yeah, it can affect your grade, but let's look a little deeper than that. What effect does that misstep have on the patient? And that's really what you need to be looking at. If I don't make sure the patient is in the middle of the bed, if I just turn them on their side and they're super close to the edge of the bed, I really shouldn't be concerned about what that's going to do to my score. I should be way more concerned about what that's going to do to the patient. If you can make that little change in your brain and you can make sure that you're focusing on the patient, you'll make sure that they're in the middle of the bed. Because if you look at them and they're too close to the edge of the bed, it'll trigger, oh my gosh, they're too close. Let me scoot them back toward me a little. So the secret to the test is to pay attention to the patient, not your steps. Does that make sense? Okay. All right. So this has step-by-step instructions. Supplies are really easy on this one. You've got a barrier for the table. You've got a bath blanket to keep the patient covered, and we've got 3 pillows. So supplies are pretty easy. Another question that you guys are going to come up with probably next week, because we get into some bigger skills next week, is, do I have to know all the supplies? Yes, you do. You have to memorize all these supplies. Because as the nurse, if I ask you, hey, can you go in and do a partial bed bath in room 4? I'm not going to tell you, can you go in and do a partial bed bath in room 4, but take a basin, soap, lotion, clean gown, privacy blanket, 4 washcloths, and 2 towels in with you. I'm not going to say that. I'm just going to say, hey, go give a bed bath in room 4. So you are responsible for knowing what supplies you need for each skill. Flashcards will help you with this. You've got at the bottom of every skill, you've got the supplies needed for that skill. And it even has a little picture that shows you what those supplies are. So you can make your own flashcards on this. Just get some index cards, write the name of the skill on one side, the supplies on the other side. Now, if you want them already done for you, our flashcards do that. They have all of the supplies and they have the pictures as well. So keep that in mind. Remember that you can get the flashcards for $15 while you're enrolled in the class. You can make flashcards for yourself at home for free. Up to you. So let's talk about scoot and roll. Remember that when you were a baby in a crib, those cribs kept you safe until you started to climb out of them. When you start to climb out of a crib, it no longer keeps you safe. In fact, it increases your risk of injury because now you're falling from a taller height. That's exactly what side rails do. When babies start climbing out of cribs, we take them out of the crib and put them in a toddler bed. We have to understand this action, this mechanism, to understand why side rails do not keep your patients safe. Positioning rails are half rails. They're half rails. They don't restrict the patient's ability to get their legs out of bed. If the patient's legs can swing out of bed freely, it's not a side rail. So half rails or positioning rails, those can be used. Anything that restricts the patient from getting out of bed safely is a side rail and requires a doctor's order. So let's talk about immobile patients. Now, immobile means patient cannot move on their own for whatever reason. It could be a muscular problem. It could be a nerve problem. They're paralyzed. It could be a weakness problem. It could be an illness problem. There's a lot of reasons a patient might be immobile. We have to understand what that means. So an immobile patient is unable to move on their own, either partial or full. There's things they need help with. If the patient is fully immobile, unable to move at all on their own, so think paralyzed or in a coma, which isn't a technical term. We call that unresponsive. That means everything is going to have to be done for them. Everything. Everything. If a patient cannot move on their own, they cannot get up and go to the bathroom. If the patient can't move on their own, they're not going to brush their own teeth. If the patient cannot move on their own, they can't do anything for themselves. We have to do it all. But all requires something that you probably aren't aware of. So let's talk about what happens in the body when we don't move. And your body, every system in your body requires movement to function properly. Every system. Your brain requires good blood flow, strong blood flow. Remember, your brain is way up at the tippy top of your head. It is fighting gravity. So we need good, strong blood flow to push the blood up to the brain. So if we don't have good blood flow, if we don't have good oxygenation, if we don't have activity, our brain may not work all that well. Make sense? Your digestive system requires movement. The food that goes through your intestines are smooth muscle. They don't move on their own. They require your abdominal muscles to move stuff through your intestines. So if you aren't moving, that means the food is just kind of sitting in those intestines and we can end up with constipation. And we're probably not going to absorb as many nutrients. Make sense? It can also cause reduced lung volume, decreased bone density, muscle atrophy, diminished immune response, and affects cognitive function. Every body system in your body is affected by immobility. Guys, this is why they say we should have at least 15 minutes of cardio a day. Every body system you have will work better. At least 15 minutes of cardio a day. Now, we probably don't get that. I know I don't get it every day. Thankfully, I have a dog who thinks that his whole mission in life is to walk around the block at 5 o'clock every evening. And he will bother me until I get up and I take him. So thankfully, he holds me accountable. And I try to go around the block with him, even when I don't feel like it. Some days I do miss, my husband will tell you. But most of the time, I can force myself. And I'm forcing myself not just to make him happy, but because I know this. In order for my body to function effectively, I need at least 15 minutes of cardio. All of my body systems are relying on it. But there's something else that movement does. And you guys are going to help me illustrate this. So what I want you to do right now as you're sitting in your chair is take one of your hands and put it underneath your leg. I want you to sit on one of your hands. I'm going to ask you to do this for 2 minutes. You're going to want to pull your hand out. Please don't. Play along with me just so I can show you this. It's only going to take 2 minutes. So let me explain to you what happens. In our body, we have bones. Those bones are covered with muscle, and gravity is pulling down. So when we're laying down, we have something called pressure points, where gravity is pulling the weight down through the muscle or through the bones into the muscles. This happens at the back of the head, the shoulders, the elbows, the coccyx, the back of the thighs, the back of the calves, and the heels. And this downward pulling, this is what you're experiencing with your hand right now. This downward pulling is taking that bone and pushing it into the muscle. Well, the next layer is that fat layer. Remember we talked about that fat layer? And then below that are your blood vessels and your skin. So when we have all of this weight and all this pressure pulling downward, and the very last bottom piece of this is the skin, that means the skin is what's going to be affected. Make sense? It's the bottom of the pile. Now, in between the skin and the muscle are your blood vessels. So as all of this compression happens, your blood vessels start to shrink, get smaller, compress, 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 shut off. So when we have a lot of pressure and that downward pressure affects those blood vessels and crimps them off, now I don't have good blood flow to that area of the skin. It doesn't take long for this to happen. You guys are already going, I want to take my hand out. Don't yet. We're almost there. Almost there. Just a few more seconds. So as we compress these blood vessels, we're not getting good blood flow to the skin. And the skin is going to start to show some changes. So go ahead and pull your hands out for a second and take a look at them. Do you see color changes on your hand? You see color changes? Look really closely. Can you see the impression of your clothing, the weave of your clothing, or the pattern of the chair on your skin? Can you see that? That was only 2 minutes, guys. You had skin changes in 2 minutes, and you were not perfectly still. You were not perfectly still. And you wanted to pull your hand out because it was getting uncomfortable. That's your brain signal of saying, hey, too much compression, you need to move. Now, you do this yourselves without even thinking about it. This is why you're never completely still sitting in those chairs. You are putting your foot up over your knee, and you're going to switch your legs at some point. You are slouching and slumping. You are leaning on the table, and in a few minutes, you'll change position. You're wiggling your feet. You are constantly in motion, even though you're sitting still. That is because of this pressure dynamic. And this pressure dynamic that prompts movement even happens when you sleep. So when you go to sleep at night, and you're like dead to the world, right? You're not aware of what you're doing while you're sleeping, but you never wake up in the exact same position as you did when you went to sleep. And that is specifically because your body responds to that pressure. When your blood vessels get compressed too long, your brain says, hey, move. So you roll over, or you stretch, or you kick, or you do something to relieve that pressure. You do this without even thinking about it. You do it awake and you do it asleep, as long as your body is physically able to move. Make sense? Okay. So this is specifically designed to help keep our skin in good shape. Because if our skin goes without that good blood flow, because those vessels are compressed, if we don't get good blood flow to the skin, we end up with a pressure sore. Now, that's what this was. When you saw the pattern of the chair, that was the beginning of a pressure sore. It happened in 2 minutes, and you guys are healthy. That is the beginning of a pressure sore. If we did not move for 8 hours, if I left your hand there and you were unable to move it for 8 hours, those lines that you saw in your skin would get deeper and deeper and deeper and deeper and deeper. And eventually it would cut into the skin. And that is a pressure sore. They're also called decubitus ulcers. Now, in healthy people, this takes a little bit of time because you've got, health on your side. If you're not healthy and you're not taking in good protein and you're not well hydrated and you don't have a lot of muscle mass because you're elderly, it doesn't take hours for this to happen. So you've got to be able to move yourself in response to these pain cues. If you can't move yourself, somebody has to move you. Make sense? Good. So these changes on you only occurred in 2 minutes. Imagine if you left your hand there for hours and hours. And this is why you change position frequently. Patients that cannot change their own position frequently have to be turned by us every 2 hours around the clock. Do not let them sleep through the night. You're not doing them any favors. Those blood vessels do not know, hey, it's nighttime. Don't cause a skin breakdown. It doesn't work like that. So that means that every 2 hours, or as often as directed in the care plan, we are going to change this person's position. Make sense? Good. So the way this works, every 2 hours around the clock, this is called a turning clock. You guys are actually able to make these as CNAs and put them on the wall of your patient's room. This is within the scope of practice of a CNA, is to make a turning clock. A lot of facilities already have them. They'll be on the wall. But if I, as a nurse, if I walk into a patient's room at 10 a.m., where should this patient be? On their back. So I can look at the chart on the wall. I can say 10 a.m., the patient should be on their back. If they're on their left side, I know they haven't been turned yet, so I can turn them. I know where I'm going to turn them to. Keeps everybody on the same page. Make sense? So a lot of facilities use turning clocks on the wall. It also keeps us accountable. And sometimes we need a little accountability because we're busy. It's okay. But the way this works is very specific. Patient will start out on their back. 2 hours later, they go to their right side. 2 hours later, back to their back. 2 hours later, left side. 2 hours later, back to their back. We never put an immobile patient on their stomach. Stomach is not on here. Never put an immobile patient on their stomach, because there's a lot of reasons your patient might be immobile. Could be nerve-related paralysis. It could be muscle-related. It could be illness-related. It could be injury related, but there's a lot of reasons a patient might need some help with turning. The problem is some of those will be affected by gravity. If you put somebody on their stomach, all of their weight is pressing down onto their lungs. And if they can't lift their chest off their lungs to inflate their lungs, they will suffocate. So unless your care plan specifically tells you to put the patient on their stomach, we don't do that. That's called prone, by the way. That position is called prone. If your care plan does not tell you to put your patient in a prone position, please don't. You can actually kill them that way. So every 2 hours around the clock, back, right, back, left, back, right, back, left, back, right, back, left, forever and ever until the care plan tells you to stop. Questions? But when we turn the patient, they have to end in the middle of the bed. That way they're safe. We can't use side rails to keep them safe. So we need to make sure that they're in the safe zone, the middle of the bed after the turn. So in order to do that, we're going to scoot them toward us and then turn them on their side away from us. So after their turn, they're in the middle of the bed. Good? Questions on this? If we don't do that, if we don't scoot them toward us, that's what's going to happen. Your patient's going to be so close to the edge of the bed that they might fall. We don't want that to happen. So we're just going to ask them to scoot toward us and then roll them to the side so they're in the middle of the bed after the turn. Now we can use a draw sheet to make this happen. A draw sheet is just a flat sheet under the patient that we use as a sling to pull the patient's body weight toward us. We usually fold that flat sheet in half so it's a little bit thicker, has a little more mass to it to help handle the weight of pulling the patient toward us. When you're using a draw sheet, though, and this drawing, you may not be able to see it because you guys are kind of far away. The folded edge, when you fold something in half, the folded edge goes under their shoulders. So like this sheet right here, if I were to fold it in half, this folded edge would go under the shoulders. The free edges, the part that's overlapping, those go under the thighs. The reason for that is those free edges are going to press more pressure. We want the pressure in the lightest area. Shoulders are going to be heavier than thighs. Good? Make sense? We also want to make sure there's nothing underneath the patient. Any wrinkles could cause bed sores. Hearing aids can cause bed sores because it's more pressure. It's a foreign object underneath the body. Make sense? Good? I have seen lifesavers that caused a pressure sore. Earrings, hearing aids, pens, all kinds of stuff. Make sure there's nothing underneath your patient if they cannot move on their own. So once we get the patient toward us and we're ready to turn them on their side, we're going to use a very specific turning process. This is all prep work. If you prep your patient properly, you can turn somebody 3 times your body weight with no stress on you or them. It's all about learning how to set it up correctly. Now, if I just go up to this patient just as she is and scoot her toward me and try to turn her on her side, I've got to put my hand on her shoulder and her hip, and I'm really going to have to struggle to get her turned. So let me show you what I mean. So if I've got her scooted toward me so that she's in the middle of the bed after the turn, I've really kind of got to see how her arm goes back. I've got to really struggle there. That is going to injure the patient because my hands are having to dig in to push her on her side. Could probably irritate me as well, my back and my muscles. It's a lot more effort. So instead of doing a log roll, we're going to position the patient so that they turn super easy. And the way that we do that depends on which side of the bed we're going to be on. Remember, we always turn our patients away from us, right? Everybody remember that? All right, if you look in your book on page 139, look at the care plan at the top of the page. Which side does it tell us we need to put our patient on? Left. And that was according to that turning clock. Turning clock said left side. I got to turn the patient on her left side. Well, if I know that I always turn the patient away from me, and I've got to turn her onto her left side, that tells me which side of the bed I should be on. The right. Correct. You guys understand that? Following that? Okay. So if I am on the right side of the patient, which is what this is showing, if I'm standing here on the right side of the patient, that's going to affect how I set this up. The furthest arm away from me, so remember, I'm on that side of the bed. The furthest arm from me, if I'm over here, goes above the head. The closest arm, remember I'm standing here, crosses the chest. The closest knee, this one, would be bent with a foot flat on the bed. The furthest knee gets angled out. Now, when I do that, your patient's like this. I have no balance. When I do that, it's a very simple roll because the patient is already, the majority of the patient's weight is already shifted to that side. So you can turn somebody 3 times your body weight with no issues at all. I used to work with bariatric patients. These are patients back in the 80s and 90s that were getting ready for surgery. These are very morbidly obese patients, 500-600 pounds. They were homebound, bedbound. And I used to go in and take care of them before their surgeries and then for a few weeks after. And I could turn somebody. Back then, I was way smaller than I am now. But I could turn somebody onto their side, 500-600 pounds all by myself. And it's all about prepping them properly before the turn. This, if you do this right, is no stress on them or you. Make sense? Good. You will. You will. So we have to know how to set this up properly to to know how to turn the patient with no stress. Now, I'm going to time out real quick and answer your question. When you go to test, the evaluators know exactly what skills you have because it's coded into your Prometric ID. So they can look at your ID and they know exactly what skills you have. Just looking at that number. Okay, make sense? Good. So you come and check in. And I look at your ID and now I know what 3 skills you have. You won't know, but I do. I know what 3 skills you have. And I know that one of your skills is side-lying position. So as everybody else gets checked in, I am thinking, okay, you're going to have to turn somebody. I need to find somebody your body size or smaller for the test. So when she checks in, I now know that she is going to be your patient. Make sense? Now, that could all go sideways if one of her skills is mouth care and you just had oral surgery and you got some stitches. Well, now she can't use you to do mouth care on because you got stitches. So I would have to look a little further and find somebody else. Good? This test is way more scientific than you guys think it is. Everything has been thought about. There's no accidents during the test. So, to review, furthest arm goes up, closest arm crosses the chest, closest knee is bent, furthest knee is angled. And then it's just a simple matter of turning them. But remember, after the turn, where do they need to be? In the middle of the bed. Good? Now, once we get them on their side, we got to do something to keep them there because they're not going to stay there on their own. Gravity will pull them back onto their back. Not might, it will. It just will. Gravity's strong. So we're going to put a pillow behind their back in a roll. And that pillow is specifically there to keep them on their side. So it's got to be kind of firm behind the back so that they don't roll. I'm going to show you the video on this one because it's got really good close-ups of that pillow. That is the hard pillow for this skill, is getting that pillow behind their back in a roll, but tucked in far enough that it doesn't flop out. Then you're going to come around to the side, put one in between their legs. Now, we don't want their legs laying right on top of one another. It's a lot of pressure. So you want their legs a little offset, and we want a pillow in between those legs so that those bony areas don't rub together. So that pillow needs to be between the knees and the ankles so those areas don't rub. We're going to come up to the front and we're going to put a pillow under that top arm so the arm doesn't sag down, which can put a lot of pressure along the neck and upper back. And then there's already a pillow on the bed under their head. But when you turn them, that pillow is going to be under their shoulder. We don't want that shoulder scrunched up. So we're going to adjust the pillow under the head. Now there's one change that I need to tell you about from the video that you're seeing. This is actually the video I'm working on right now to redo. I don't have it done yet because my computer has died. So the guy is at my house right now fixing my computer. So thank you, Tom. Okay, so when you turn the patient over onto their side and you put their pillow behind their back, between their legs, under the top arm, and adjust the pillow under the head, the call light, when you put it in their hand, this call light, you have to put it in their bottom hand, not in the top hand. And that's because we don't want that cord over the patient's neck. So the call light goes in the bottom hand so that cord doesn't accidentally strangle them. Questions? Questions? So this hand, right? This hand goes up, this hand goes across. When you turn them, that hand is like this. When you're sleeping, you probably put your hand under the pillow. It's the same thing, right? So it's kind of our sleeping position. When you're sleeping on your side, you've got an arm up, but it's probably under the pillow. And that's usually what I do is I'll tuck that arm under the pillow just to make it comfortable for the patient. Think of a natural side sleeping position. Good question. Any others? Let me show you the video for this one. Can I get you to turn the light off for me? I'm not going to cover the window today, but if you can turn the light off. Oh, okay, hold on. We have a congratulations. I love congratulations. Chris says, passed my exam yesterday. Thank you. Love you guys over here. Oh, thank you so much. Congratulations. We're super proud. Good job. Oh, thank you, Latchman. That's so sweet. Latchman says, thank you for another amazing class. Okay. Give me just a second. Uh-oh. Hold on. Okay. Give me a second. I got to fix something here. No, 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 no. Hold on. Oh, that is very annoying. Sorry, guys. Give me just a second here. It does this occasionally, and I don't know why it does this. So, all right, I'm going to have to run this through my computer. Okay, let's see. Okay, Fire TV. Let's try that. There we go.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to turn you onto your left side. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies, and I'll be right back.
Okay.
I'll start gathering your supplies. We'll start with a barrier, which I'll place on the table to provide a clean area to place my supplies. And I'll get 3 pillows from clean supply cabinet, being careful not to allow them to touch my uniform. Mr. Jones, I'm going to place this blanket over you, and this will help keep you warm and protect your privacy while we do this skill. Once I have the blanket in place, then I'll pull the sheet down underneath the blanket, making sure the patient remains covered at all times. Okay, Mr. Jones, if I could have you scoot toward me, please. I'm going to place your furthest arm above your head and cross your closest arm over your chest. I'm going to bend the closest knee and put the foot flat on the bed. And I'm going to angle the furthest knee out a little bit. Okay, now I'm going to turn you onto your side. 1, 2, 3. Okay, I'm going to take the first pillow and put it in an angle up against the back, and I'm going to tuck this top edge underneath the patient by pushing down on the pillow and under his back. This edge will roll up, and then it too will be pushed down and under, forming a roll along the back. Okay, now I'm going to position a pillow between the 2 legs by lifting the top leg and laying the pillow lengthwise between the 2 legs, specifically between the knees and the ankles, to prevent those bony areas from rubbing together. This pillow is going to be placed underneath the upper arm. This will help keep the arm in a neutral position as the patient remains on their side. And then I'm going to adjust the pillow underneath the head to make sure that it's not under the shoulder and it remains only under the head and the neck. And then move the arm to a more comfortable position. Is that comfortable, Mr. Jones?
Yes.
Okay, I'm going to place the call light directly in your hand. Are you comfortable?
Yes.
Can I get you anything else while I'm here?
No.
Okay, let me pull your sheet up. And remove the privacy blanket. Being careful not to dislodge all of those pillows as I do so. I'll roll the privacy blanket up and place it in dirty linen. The barrier will be thrown away. Okay, Mr. Jones, I'm going to open your privacy curtain now. Is there anything else I can get for you while I'm here?
No, thank you.
Okay, I'll see you soon. Let me go wash my hands. After washing my hands, I'll review all the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay, guys, can you hear me? If on the chat online, if you can hear me, can you let me know? Give me a thumbs up or something. I just worked on the sound. I'm hoping you guys can hear me. Just let me know. Takes a while. There's a delay. It takes a while. All right. Hopefully the sound is coming through. Okay. Any questions on that one? Remember, call light goes in the bottom hand. Any questions? Do you guys understand a little bit more about immobility and the risks associated with patients? So if we don't have a patient that can move on their own and there's nothing in the care plan about turning a patient every 2 hours, what would you do with that observation? If the patient isn't moving on their own and there's nothing in the care plan about turning them, go to the nurse. Absolutely, because it is possible that the nurse may have overlooked that. You know, they get distracted, they get busy, phone calls come in, doctors come in, lab work comes in that has to be reviewed. There's a lot of things going on, and the nurse just may have overlooked that. And unfortunately, it's the patient that's going to pay the price for that. So if you notice that, please bring it to your nurse's attention. Hey, do we need to turn that patient? All right. Any other questions? The hand under the pillow. Yep. Yep. And that's, like I said, I'm in the middle of doing that particular video, and I've got some really good close-ups of putting that call light in the hand under the pillow. All right. Any other questions? Let's go ahead and take our break, or we're going to take the break now because the next skill that we get into, foot care, I've got a long lecture I have to give you on diabetes. So I'd rather get the break out of the way before I get into that lecture. So go ahead and take your break. We're on 47. Oh, thank you guys for responding. I appreciate it. Okay, we'll be back in 15. And we're back. Okay. Let me just make sure that you guys can hear me virtually. Can my virtual people hear me? Oops, there we go. Just let me know. I know I'm slow in answering today, guys. I'm so sorry. But we'll get through it together. Okay. If you guys can't hear me, please let me know. Okay, good. Thank you. Thank you, guys. Okay. So now we're going to move on to foot care. This is on page 118 of your skills book. Down here, you'll see all of the principles involved in this skill. Now, this is a little bit of a longer skill. Somebody with your level of experience should be able to do this in 13 minutes or less. When you read the care plan, you'll see it's really not all that complex, but it is a longer skill. And man, there's a lot of principles involved here. Lots of principles. We're going to read that care plan. We're going to do our opening, evaluate if we need gloves, use a barrier, linen rules apply. We're going to use washing rules, and then we're going to clean our basin the way we clean everything else. We'll follow up with the closing. So a lot of principles here. This is going to be done on another live testing student. So that means that you guys might be a patient for somebody doing foot care. I know. Nobody likes people messing with their feet. It is, however, a great excuse to have to go get a pedicure first before the test. So if you need an excuse, there it is. I don't like this skill because I can't get down on the floor anymore. My knee just doesn't bend that way. So to me, this is the hardest skill. It is absolutely the hardest skill to do. Those of you who can get on the floor, this is one of the easier skills. All we're going to do is soak a foot, wash a foot, rinse a foot, dry a foot, and lotion the foot. That's it. That's all you're doing. And for the test, we're only doing 1 foot. But that's not why you're there. You're not there to clean the foot. That's what you're doing, but that's not really why you're doing it. So there's no new principles to learn here. If you look at the top of page 119, you'll see the care plan. It says provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. Now, the reason that last sentence is there, where it says the sock and shoe should be replaced, is because you guys are the patients for this. In a clinical setting, if she were in a nursing home and I did foot care on her, I would put a new pair of socks on her. Clean feet need clean socks, right? But for the test, you guys aren't taking clean socks with you. There are no clean socks to put on. So the care plan is telling you what to do for the test. Put their sock and shoe back on, the one they came in with. Good? Make sense? Okay, in a clinical setting, please put a clean pair on the patient. All right, so this is just like hand and nail care without a few steps. So with hand and nail care, we soak the hand. Well, with foot care, we'll soak the foot. With hand and nail care, we took the hand out and washed it. With foot care, we'll take the foot out and wash it. With hand and nail care, we put the hand in the basin to rinse. Well, foot care, we'll put the foot in the basin to rinse. It's exactly the same. It's after that that things go a little bit sideways. With hand and nail care, we cleaned under the nails. With foot care, we don't do anything with nails. We don't clean them. We don't trim them. We don't file them. We don't grind them. We don't do anything with toenails other than look at them. And that's because facilities have a podiatrist, which is a foot doctor that comes into the facility once a month, and they will see the patients that are on the list to be seen. So the way a patient gets on a list, you do foot care, see there's an issue, tell the nurse puts them on the list, and then when the podiatrist comes in, they get seen. If you don't do foot care, that patient will never get seen. If you don't tell the nurse there's an issue, that patient will never get seen because those podiatrists do not go room to room saying, you need me? Do you need me? Do you need me? They don't do that. They just go in and look at the list. So observation is the biggest task with this skill. It's not about cleaning the foot. But this is really why. It's not really about the toenails. I mean, you want to look at the toenails because everybody's got, you know, some toenail maintenance that's going to need to be done now and then, right? We all have to clip our toenails and things like that. So toenail maintenance does need to be done, but that's not why you're really looking at the foot here. So I'm going to explain this to you. Hopefully in a way that you can understand. This is a 5th grade version of diabetes. So I'm really, really simplifying this for you. Understand, for those of you online, this is not meant to be a complete expose of diabetes. This is just a very simple overview. There are nurses that go to school for years above their nursing degree to learn about diabetes. You can devote your entire career to this topic. It is that complex. In your body, you have cells. You have liver cells, you have brain cells, you have stomach cells, you have muscle cells, you have hair cells, you have all different kinds of cells. Those cells have to be fed. They require a fuel. And one of the best, most efficient fuels for the cells in your body, most of the cells in your body, is glucose. Well, that's fortunate because when we eat, a lot of what we eat are carbs. American diet, very heavy in carbs. Those carbs break down into sugar. That sugar then prompts the release of a key that opens the door to the cell and allows the sugar to go in. And now the cell is fed. Good? Everybody with me? So we eat that, those carbs that we eat break down into sugar. Our body makes something that opens the cell that allows the sugar in, and the cell is then fed. That something is called insulin. So insulin is made by your pancreas. We talked a little bit about that with the endocrine system today when I did a review on it. Remember I said all of our endocrine system tends to decline a little bit as we age? So when sugar is detected in the bloodstream, the pancreas is prompted to release insulin. And insulin is nothing more than a key. That's all it is. It's a key that opens the cell and allows the sugar to go in. If we don't have that key, that sugar can't get beyond the bloodstream. It just stays there. Have you ever heard the term high blood sugar? High blood sugar means we have lots of sugar in the bloodstream, blood sugar. The sugar is staying in the stream, it's not getting into the cells. Now, the reason that we end up with high blood sugar is that if those cells can't accept the sugar, that sugar has nowhere else to go. It can't be excreted efficiently. Like your kidneys can't just get rid of it. Doesn't work like that. So if we can't get that sugar into the cells, it just circulates. And when we eat more carbs and they break down into sugar and that sugar goes into the bloodstream, now our blood sugar goes higher if it can't get into the cells. And higher. And higher. And higher. Because if the sugar can't go into the cells, it can't really leave the body effectively. Make sense? Now, there is one thing that can be done about this. There is one trick that the body has up its sleeve. If we have sugar in our bloodstream that is not being effectively used by the cells, so the cells say, I'm starving. The brain says, I'm hungry, you go eat. Those carbs break down into sugar. Insulin opens the door and the sugar enters the cell. This is normal. But if, this doesn't work, we end up with lots of sugar outside the cell and the cell is still starving. Anybody know a diabetic? Anybody know a diabetic? What do they usually crave? Sweets, yeah. They're craving sweets, not because it's a moral weakness. It's because their cells are starving, literally dying, literally dying. That is a very strong motivation to get that cell what it needs to survive. So your cells are telling your brain, hey, I am literally dying here. And the brain says, oh my gosh, we got to get some sugar into you. So the brain triggers a craving, which is why our diabetics eat M&Ms and donuts and all the sugary stuff. It's not a moral failure. It's not because they have no willpower. It's that their cells are dying and their brain is trying to do everything it can to keep those cells alive. What the brain doesn't understand is you can eat all the sugar in the world. It's not going to fix this problem. All it does is dump more sugar into the bloodstream, which we can't do anything with because we can't get it into the cells. Make sense? I'm going to give you a little key for that in just a minute, a way to help your patients that are craving sugar. But understand, if you've got a diabetic that's craving sugar, this is what's happening on the inside of the body. Their cells are dying. Cells are dying. So the body has one trick up its sleeve, just one. It says, okay, well, if I've got all of this sugar hanging around and I know it's not good for me, I'm going to pack some of that up in a storage box and maybe we can use it later. So that's what the body does. It takes this excess sugar and it packs it up in a box, and we call that glycogen. And it shoves that glycogen in a storage unit for later. Those storage units are your fat cells. Your fat cells are storing glycogen for use later. And what that does is it helps reduce the amount of sugar in the bloodstream. And that's good. That's good. We solved this problem, not as much sugar in the bloodstream. And we got some sugar on board that we can use later. The problem is that if we don't unpack that sugar and use it in a timely manner, it doesn't last all that long. It's not very useful 15 years from now. It would be like, have you guys ever watched that show Storage Wars? You know, where they buy a storage unit kind of sight unseen, they bid on it, and then they go in there and a lot of times it's just junk that you can't really use. That's what happens here. When the body puts all of this excess sugar in a box and puts it into the storage unit, yeah, we can use it, but if it's 15 years from now, that stuff is so outdated, it's not really going to be useful to anybody. That's what happens. And this is why it's so hard to lose weight, because we can't effectively burn fat that's been stored for a long time. It's just not as useful to us. Starting to see why it's so hard to lose weight? Okay. He's putting these pieces together. Okay. So why do we care? This sugar that's in the bloodstream, and as we run out of fat cells, the sugar in the bloodstream tends to go up. And this is when we get our diagnosis of diabetes. Diabetes is high blood sugar. That means all that sugar, we're not putting it in the fat cells anymore because they're full up. It won't go into the cells. It's just in the bloodstream. Well, why do we care? So what? We got sugar in our bloodstream. Just makes us sweet, right? Well, here's what happens. So this is a normal artery, a good artery. See how wide open that is? Lots of room for blood flow. You guys see that? This is a good artery. This is how our arteries are when we're born. I would love to see that artery again. Mine do not look like that. Because with the American diet, we eat a lot of carbs. Now, carbs get a bad rap in our society. Carbs are not bad. Your body needs sugar to run. The cells need it to run effectively. Carbs are not bad. Carbs in excess are bad. Remember, you can't excrete sugar. So anything you're not using by your cells, it has to be stored. Carbs in excess are bad. But what happens is when we run out of storage units, that sugar has to go somewhere. Has to go. It can't just circulate in the bloodstream forever. It's got to go somewhere. Have you ever seen a cupcake or a cake left out on the counter for a couple of days? What happens to the frosting? It gets hard. So the oil and the crystals separate. Sugar is a crystal. It actually, under microscope, looks something like this. You see how jagged that is? Well, these crystals actually line the inside of your arteries. They settle. They line. So that makes your arteries stiff. And you've got all these jagged points. So everything that's floating by these jagged points are going to get all caught up in these jagged points. So cholesterol, which looks like pizza cheese, by the way, cholesterol looks just like pizza cheese in your arteries. When that floats by, it's going to get all tangled up in this. And you're going to end up with this big goopy mess. And when that happens, your arteries start to decrease in size. Do you see the size difference between these two? It's minimal. It's a small difference, but there is a difference. Now, because this has a smaller interior diameter than this, the hose is smaller. That means that whatever blood is in here is under more pressure. We call that blood pressure. So when we start to decrease the diameter, when we get gunked up, we get higher blood pressure. You connecting those two? Now, if we don't pay attention to this and we don't change our ways, by the time we're in middle age, we look more like this. Now, this is high blood pressure. This is probably somebody that's on high blood pressure medication. This is not good for us. And this has everything to do with this. Because the arteries are stiff because of all those crystals, and they're capturing everything that goes by, including white blood cells, which is your immune system. So what is that going to do to our ability to fight infections? Yeah. We have a decreased ability to fight infections because all of our blood cells, instead of going where we need them, are all stuck here. Platelets, which causes you to stop bleeding, they're all in here. So what happens if our patient starts bleeding? Doesn't stop. So a lot of problems here, right? A lot of problems. Now, if we don't fix this, if we don't get serious about it, then we end up with this. Now, anytime blood slows down or stops, it clots. And that's what you see here. This is a blood clot. When it happens in the brain, we call it a stroke. When it happens in the little teeny tiny vessels of the heart, we call it a heart attack. So our diabetic patients, their arteries look like this, and they're at higher risk of stroke and heart attack. So probably not a good thing, right? Good? Makes sense? Do you understand a little bit about that connection? Okay, so why do we care? Well, because of gravity. On planet Earth, we have gravity, and gravity pulls heavy things down. The heavier the thing, the harder gravity pulls on it. Good? This is heavy. Crystals are heavy. So, if we know gravity is pulling heavy things down, what is the lowest point of my upper body? Hands, fingers. What is the lowest point of my lower body? Hand care, foot care. That's why we do these two skills. We are looking for problems in the hands and problems in the feet, because if our patient has diabetes, they may not be able to feel or see the problems that are there. Remember we talked about musculoskeletal changes with aging? We get less bendy as we age. You can look at the bottom of your feet. You guys are all young and bendy. When you get older, you are not as bendy. You will not be able to see the bottom of your feet. Now, this is pretty bad, isn't it? Pretty bad, but it gets worse. It's not bad enough, it gets worse. Because all of these crystals don't just settle on the inside of our arteries, making them stiff. They also coat the nerves of the body. So we can have somebody that has an injury at the bottom of their foot, and that foot knows the injury is there, but that signal cannot get from the foot to the brain because the wire that it has to go through is corroded. And this is where we end up with neuropathy. So it's very likely that your diabetic patients are going to have injuries that they aren't even aware of. They can't feel them. So let me give you a story about this. True story. Many years ago, I was an agency nurse. Now, agency nurses are substitute nurses. Just like you have a substitute teacher in high school, substitute nurses. I don't work for the facility. I'm sent in because they don't have enough nurses that day on staff. So I go in, I get my report, and I'm visiting each patient doing my assessments. And I walked into this patient's room. As I walked in, the room was dark. He just had one small light on, one of these small fluorescent lights above his bed. The rest of the room was dark. So I walked in, I've got to assess him, so I flipped on the light. And he starts yelling right away, "Turn it off, turn it off." So I turned the light off and walked to the bed and I said, "Hey, I'm Patty, your nurse. What's going on? Why don't we want the light on? Do you have a headache or something?" People generally don't react that way. So there's a story there. I got to get to the story. He says, no, I've got diabetic retinopathy and the bright light really hurts my eyes. So I don't like the big light on. It affects me. I said, okay, no problem. So as I'm standing there, I'm catching an odor. Now, if you've ever smelled a wound, they're very distinctive. And I know this guy has got a wound somewhere. I can smell it. So I pull out, as we're talking, I pull out my report sheet and I just start scanning, and there's nothing on this report sheet about wound care. Uh-oh. Please don't tell me I'm the first one to find this. So I sweet talked him, because you can always get further with patients by being nice than being mean, always. So I turned up the charm and I said, "Hey, I think you might have a wound brewing somewhere. Can I take a quick peek?" Now, let me tell you a little bit about this patient. He was in his 50s, very young, and he was very gruff. He wasn't married. He had no kids. None of the staff liked him. He was on the rehab side where he had gone to the hospital, had a surgery, but he couldn't go home yet because he didn't have anybody to take care of him. He was a military vet, and he was not the most pleasant person, right? So he says, do what you got to do. So I turned him over and I looked at all the usual suspects. And we saw that slide just a few minutes ago. I looked at the back of the head, the tips of the ears, the shoulders, the lower back or coccyx area, the back of the legs, the back of the calves, and get down to his feet. I'm not seeing a whole lot yet, but when I got to his feet, he had those slipper socks on, the kind with the dots on them. Yeah, it helps you not slip, and they're very popular in clinical settings. So I said, hey, can I take your socks off and look at your feet? And he immediately barked, no, leave my feet alone. Okay, there's my red flag. Because if he's telling me no, what did he tell the CNAs? No, so we have no idea how long this guy had gone with nobody looking at his feet. No idea. Because they didn't report it. So I turned up the charm, finally got him to agree, and I took the right sock off, and his foot was flaky, could definitely use a little washing, but okay. Tried to take the left sock off, and it stuck to the bottom of his foot. Found it. There's my problem. So I go get a basin of warm salt water. We call it normal saline, but I go get a basin of warm salt water, and I put his whole foot in it, sock and all. Put everything in there, and I go take care of another patient. I come back 10 minutes later, and I had to use a little bit of pressure to get the sock off, but I got to look to see what I'm dealing with here. I can't just leave the sock on. So I put a little pressure as I was pulling that sock off, and when I did, something went flying past my head. And I started counting toes just to make sure, and all of his toes were there. That's good. So what went flying past my head? Now, the baseboards were like these baseboards, the tall kind of plasticky baseboards. And the floor was like a clinical floor, kind of speckled. So it took me a minute to find it. But up next to the baseboard was this. This is a white painted metal thumbtack that had been in the bottom of his foot. Now, he did not feel it because of this. He had no idea there was anything in the bottom of his foot, and he certainly couldn't get down there and look at it. So I look at the wound, and I know this guy's had this thumbtack there for quite a while, because the area that I'm looking at is about this big around. It's kind of irregularly shaped, something like this, about that big around, and it's hard black dead tissue. Now, we're good in healthcare. We can fix a lot of things, but we can't bring things back from the dead. And this tissue was absolutely dead. So I know this guy is about to have a really bad day. So I call the doctor. I call the family. I call the wound care specialist. I took pictures. I documented everything. And then I went home because it's not my facility and it's not my patient, and I'm done with my shift. But this guy stayed on my mind for quite some time because he was so young. 50s is young to be in a facility. So about 8-9 months later, I don't know the time frame, I get assigned back to that facility. But this time I'm on the long-term care side, the nursing home side. Before I had been on the rehab side. Now I'm on the long-term care side. And, pulling up, my brain kind of went to that guy, and I wonder idly how he's doing. And I go in and I get report, and oh my gosh, his name is on my list. So that tells me that he didn't get to go home. He is now living in a nursing home in his 50s. That's sad. So I walked in and I said, hey, I'm the nurse that found the wound on your foot many months ago. How are you? He pulled the sheet back, and he had to have a below the knee amputation. He lost his leg off of this. He lost his leg. Now, to me, this is tragic for two reasons. The first reason that it's tragic is that if the CNAs had just reported that he was refusing foot care, some nurse could have addressed this earlier when we had a chance to maybe, possibly heal it. So the CNAs kind of failed here by not reporting this. But the real tragedy here is that it didn't have to happen at all. Because if this person had shoes on while they were walking, where would the thumbtack be? We don't have to amputate shoes. So this was a completely preventable injury. When we have a patient that has limitations in what they can feel, it's our job to protect them. Does that make sense? This was horrible. This was horrible because it didn't have to happen. So we actually have a rule for this. If our patient's feet hit the floor, we have to talk about their shoes. They should have shoes on. If they don't have shoes, let the nurse know. The nurse has got a social worker friend that they can call up and say, hey, Henry doesn't have any shoes. Social workers have gift cards and they can go buy Henry a pair of shoes. Social workers can call up the facility Henry came from and said, hey, can you send over some of Henry's shoes? So social workers can call the family and say, hey, Henry's here. Where are his shoes? We've got resources. But the problem is that nobody knew that Henry didn't have shoes other than the CNAs, and they decided that it wasn't worth mentioning. This guy lost his leg over that. That's a heck of a price to pay. Good. Now, why am I going over this? Well, it's because as CNAs in our current modern age, the majority of your patients over the age of 60 are going to have diabetes. This has become an epidemic. But let me explain to you how this happens. This is not something you catch. We don't all of a sudden have a whole lot of old people with diabetes because it's contagious. It's not what happened here. Diabetes starts when you are 2, but you don't realize it. So let me explain how this works, because all of you are at risk right now too. When a small child gets up, we live in a convenience society. We live in a convenience society. So when a small child wakes up in the morning and mom's not quite ready to get up, mom will go lay on the couch and hand the kids something to snack on, like a Pop-Tart. And that Pop-Tart are carbs. Carbs break down into sugar. Sugar fuels the cells, but any excess sugar is just going to circulate. Mom finally wakes up around 6:37 and pours the child a cup or a bowl of cereal. Now, kids aren't eating all bran, are they? They don't eat shredded wheat. What do they eat? Yeah, Fruit Loops, Fruity Pebbles, Captain Crunch, all the good stuff. They even have one called Cookie Crisp. I mean, isn't that awesome? But that is pure carbs, and carbs break down into sugar, and sugar goes into the cells to fuel them, but the excess hangs around. Mid-morning comes around. Mom's a good mom. She gives the child a snack, some fruit, because fruit is healthy, but fruit breaks down into fructose, which is a sugar. And that sugar will fuel the cells, but anything excess will just circulate. Lunchtime, chicken nuggets and mac and cheese. Now there's a little protein there, but there's a whole lot of carbs. Those carbs break down into sugar. Every time we eat carbs and they break down into sugar, your pancreas has to accommodate by pushing out insulin. So first thing in the morning, Pop-Tarts, we pushed out insulin. Cereal, we had to push out insulin. Fruit, we had to push out insulin. Mac and cheese, we had to push out insulin. So Afternoon snack, probably a little Debbie something, which is pure sugar, and that makes your pancreas push out more insulin. Dinner, we're going to have some buttered spaghetti and a salad. Kids not going to eat the salad. They eat a few pieces of spaghetti, and those are all carbs, which breaks down into sugar, and your pancreas has to produce insulin. And then no child goes to bed without dessert, which is a sweet something. And that makes our pancreas produce insulin. So these eating habits are established very young in somebody's life. And the lessons we learn when we're young stick with us. And this is the eating habits that Americans adopt. And we keep these eating habits up throughout our lifetime. So by the time we get to 60, your pancreas is like, hey, buddy, you've overused me. I'm out. I'm done. You're on your own. So now when you eat carbs and they break down into sugar, your pancreas is no longer producing insulin. It is done. That's why we have an entire generation of older people who develop diabetes in their later years. It's because they've overused their pancreas with their eating habits throughout their entire life. Do you see how that could be a problem? So you young people, pay attention to your carb intake while you still have a pancreas that can thank you for it. A good rule of thumb is to eat half as much protein as you do carbs. Eat half as much protein as you do carbs. Make sure you're maintaining a 2-to-1 ratio. 1-to-1 is even better. If you can get a 1-to-1 ratio, you are on a good track. But a 2-to-1 ratio will keep you pretty healthy. So if you're going to go to McDonald's and you get that large fry, well, that means that you have to have an entire chicken breast to offset it. No bun, no condiments, an entire chicken breast. If you want the bun and condiments, you got to eat 2 chicken breasts. Now, if you want the soda, you better make that 3 chicken breasts. You're starting to see how our protein and carbs are way out of whack. So while you're young, start paying attention to your pancreas and showing it some love, because it won't be there for you when you're older if you don't. Good. So we need to understand diabetes, because we're going to have an awful lot of patients that are going to have diabetes. And it all started when they were 2 because of the eating habits. Now, if the patient's feet hit the floor, we have to talk about their shoes. And that statement is designed to make you aware that we should not be walking anybody without footwear. I don't care whether they have diabetes or not, because even though they may not have diabetes now, does not mean that they're not on the road to diabetes and we just haven't diagnosed it yet. So if we're walking a patient, they should have something to protect those feet, because we don't know where they are on this journey. Now, I told diabetics to help them when they're craving. On the back of every cell is a back door. It's a very small door. It's not very efficient, but it is there. And that door is opened by protein. So remember that the whole reason for a craving is our cells are starving, right? The body is reacting to my cells are dying. Well, if we can get that patient who is craving sugar to eat a little bit of protein with that sugar, that protein will go into the cell and calm it down so it's no longer screaming, I'm dying. So if we have a diabetic patient who's shoving M&Ms in, try to get them to eat a slice of cheese with it. Cheese and apples, a half of a tuna fish sandwich, peanut butter and crackers. So the carb will help decrease the craving, the protein will help fuel the cell. Not as efficient, but it definitely will help them reduce the amount of carbs that they take in. Because remember, every carb they take in is not doing them any good because it's not able to enter the cell. Good. The worst thing you can do is try to discipline a diabetic patient for eating sweets. And I see CNAs do this all the time. What are you doing? Don't you know you cannot have sweets? You're diabetic. Are you an idiot? And they just lay into patients. That patient's cells are legitimately dying for real. That's why they're eating those donuts. No, the donuts aren't doing them any good. In fact, they're actively hurting them. We know that. But instead of yelling at them, how about giving them a little protein to go with it? That will solve the problem. Bless you. So good? Good. This is why we do foot care. Okay, so here is a question. Now, I cannot answer medical questions, but let me go through this real quick. Can you get hypertension, that's high blood pressure, because of stress and not because of a buildup of cholesterol in arteries? So I cannot give you medical advice. So this is not aimed at you. But high blood pressure can be caused by internal or external influences. Internal would be a buildup, what we've just talked about. External would be the release of different aldosterone, adrenaline, cortisol, different neurochemicals that can cause the constriction of blood vessels that could lead to hypertension. So hypertension can be caused by a lot of different factors. In fact, sodium can cause hypertension. Have you ever gone to a movie theater and gotten a thing of popcorn? Popcorn's very salty. They add a lot of salt to it. They actually do that on purpose. Now, we like salt on our popcorn because it tastes good, but movie theaters actually do this not because it tastes good, but because it gets you to buy more soda. That's why they do it. It's purely financially motivated. Now, the really funny thing is soda has a high level of sodium in it itself. So when you eat popcorn and drink soda, it actually makes you thirstier. So you go get a refill on your soda, and that makes them a little more money. But just like we can't excrete sugar, right? It doesn't go anywhere. It doesn't really excrete very well. Sodium is kind of the same thing. So it's very, very hard to excrete sodium. We do it through our skin when we sweat, but it's hard to excrete it through the urinary system. So what ends up happening when we take in a lot of sodium, that sodium has to be diluted in your blood system. We can't move the sodium out of the blood system, so the only other option is to move water into the blood system to dilute it. So because we have more volume inside, it gives us high blood pressure. That's why people with high blood pressure are told to be on a no salt diet, because wherever salt goes, water will follow. So next time you get a popcorn at the movie theater, get water with it. Doesn't taste the same though. Doesn't taste the same. I love movie theater popcorn, but I just don't go to the movies anymore because I have zero willpower. I'll eat it. So I just don't go to the movies. All right. Any questions on why diabetics need to be monitored? Why we have to use shoes? So for this skill, you're going to wash somebody's foot and then you're going to put their shoe and sock back on. If you don't put the shoe on, that tells the evaluators you don't understand this concept. Put their shoe on. Any questions on that? If their feet hit the floor, we're going to talk about their shoes. Now, that's the whole reason, guys, that we're doing foot care, by the way, is to look at the foot. That's the whole reason we're there. It's not to get that foot clean. It's to look. They figure if you soak the foot, wash the foot, rinse the foot, dry the foot, and lotion the foot, somewhere in there you might actually look at the foot. Used to be years ago, this is a new skill, by the way. This has only come about in the last 15 years. Foot care is a new skill, you know, in the history of time, because we used to tell CNAs, remember, I'm legally liable for this patient. Every part of this patient I'm legally liable for as the nurse. So my assistants, I would tell them, hey, make sure you're looking at everybody's feet at least once a shift. Let me know if there's any issues. The CNAs saw that as busy work. Man, that nurse, she thinks I've got nothing to do. She says, I got to look at your feet. Yep, you got feet. All right. And that's what they would do. And that did not solve the issue. It did not help me identify if there's anything that needs to be addressed. So because of that, foot care became a skill. Because we figured if you soak the foot and wash the foot and rinse the foot and dry the foot and lotion the foot, you would look at the foot and let me know if there's anything that needs to be addressed. So during the skill, you actually have to say, I'm looking at the foot. So the evaluators know that you know why you're doing this skill. Good. Report anything that looks, smells, feels funny. Anything. But here's the problem. We don't know if this person has a foot issue. That's the whole reason we're doing the skill. We have no idea if there's a wound there. So because there's a maybe, we're going to wear gloves for this skill. Good? Good. Slipper socks are not enough to protect from injury. I know we wear them in a clinical setting. Anybody ever been a patient at a hospital? They give you a hospital gown and those little slipper socks. This is like the mandatory uniform of all patients. Hospital gown, slipper socks. It's what you get. And man, we get all excited. We get these little, we get to take them home, right? Slipper socks. This is cool. Free pair of socks. They're only charging you $400 a night for them, but free pair of socks. You put those socks on and you climb into bed like a good little patient, but at some point you're going to have to pee. You get out of bed and you walk across that floor to the bathroom. What's in the bathroom? Oh, yeah. You do everything you need to do around that toilet when you're going to the bathroom, and then you get back into bed with those socks on. What just crawled into bed with you? Oh, man. All kinds of pathogens, like the grossest pathogens. Because I can guarantee you in the last week or so, there has been somebody that was in that bed that didn't make it to the bathroom completely. And you just walk through it. I don't care how clean housekeeping gets those floors. You're still walking on them with socks that you're going to get into bed with. And that's pretty gross. Good? Make sense? Pretty gross. All right, so foot care is actually just like hand and nail care. We're just not doing anything with the nails, but looking at them. We're going to put our barrier on the floor, though, because your patient can't get their foot up here. So we'll put the barrier on the floor. We'll put water in the basin. We're going to check it. We're going to let them check it. And we're going to put the foot in the basin to soak. Then we're going to take it out of the basin to wash, put it back in to rinse, take it out of the basin to dry all areas, and then we're going to put some lotion on. But you don't want to put lotion between the toes, because between the toes is warm, dark, and probably moist because of sweat. If you put lotion there, it's going to hold in that moisture and can predispose them to athlete's foot. No lotion between the toes. Anytime we put lotion on, we warm it up first and we wipe it off after. After we wipe that lotion off of the foot so that they don't slip in their shoes, then we're going to put their shoes and socks back, or shoe and sock back on. Remember, for the test, we only do this on one foot. You got 13 minutes to soak a foot, wash a foot, rinse a foot, dry a foot, and lotion the foot. That is way more time than you need. Good. Questions? Boy, that's a whole long lecture for such a short, easy skill. Do you guys understand a little bit more about diabetes? Okay. All right, so here's our care plan at the top, page 119. It says provide foot care to 1 foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. Please remember we will wear gloves for this because there's an unknown. There's an unknown. Plus, you know, it's feet. It's feet. Okay. So, oops, let me go. Sorry, let me go here. Okay, so let me show you this video. Can you grab the light, please? Thank you.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about yourself?
Wonderful. I need to do foot care. Is that okay?
Yes.
Let me go close your curtain, wash my hands, and then I'll gather your supplies.
Okay.
Okay, I'm going to get a barrier, and we'll place this on the floor right in front of you, and you can place your foot on the barrier. I'm going to get a basin, soap, and lotion. We'll place that on the barrier. I'm going to get 2 washcloths and a towel and a set of gloves. I'm going to get some water for washing. Okay, Mr. Jones, would you like to check the water temperature and make sure it's okay?
Yes.
Is it
Great.
good?
Yes, great.
Very good. I'm going to set this here. And I'm going to kneel on the barrier and apply my gloves. I'm going to roll up your pants leg and lift your foot so I can remove your sock. We'll place your foot in the basin to soak. I'll take the first washcloth and wring it out, making sure that your foot is wet. I'm going to place your foot over here on the towel and apply soap to the washcloth. I'm going to wash all surfaces of the foot. I'm going to lift your foot up so I can wash the bottom, and I'll observe for any red areas, wounds, sores, or any other abnormalities. We'll put your foot back in the basin to rinse. Okay, I'm going to place your foot on the towel to dry. And I'll ensure all surfaces have been dried thoroughly. I'll take one of the narrow edges and go between your toes to blot. And I'll dry the bottom of your foot. Now I'm going to apply some lotion. We'll warm the lotion in our hands. And apply lotion to all surfaces except between the toes. So I'm going to lift your foot And we'll apply lotion to the bottom as well as the top. And now I'm going to wipe off the excess lotion so that you don't slip. Okay, go ahead and place your foot back on the barrier. And now I can reapply your sock. There we go. And we'll put your shoe back on. Can you slide your foot in there for me, please? Okay, Mr. Jones, I need to put all of my supplies away now. I'm going to gather my dirty linen and place it in the dirty linen hamper. I'm going to take the basin to the sink and clean according to the basin cleaning procedure. On the way back, I'll collect the soap and the lotion and put the basin back in the drawer. Now I'll collect the barrier and throw it away. Now I can remove my gloves. Okay, Mr. Jones, are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is here. If you should need anything at all, please let me know. Can I get you a magazine while you're waiting?
No, thank you.
I'm going to open my curtain and wash my hands. After washing my hands, I'll review the steps in my skill, make any corrections, and tell the evaluator my skill is done. Oh, can you grab? Thank you. All right. Any questions on that? Foot care.
Are they going to be using the same like basin as their hands?
Yes. Yes. It's rinsed, dried, and stored. It's like a bathtub, right? When you get into a bathtub, your entire body is in the bathtub. So your hands, your feet, and all your other parts. So they consider it the same. Okay. In a clinical setting, if there's a concern, just wash it out with soap. Go by your facility policy. Remember that that basin is only used by that one person, not by other people. Okay. Questions? Good. All right. We have 2 more skills to go. This one is the next one that I'm going to show you is probably out of the 2, the most complex. This is mouth care, but you guys already know how to do this. It's brushing teeth. You probably have done that a time or 2 in your life. You're probably somewhat familiar with this. We just have to learn how to adapt it to be done on another person. So there's not a whole lot to teach you with this skill. The last one we're going to do today is respirations, and it looks just like pulse, but we got to go through a few things with respirations. So I'm going to show you these next 2 skills pretty quickly, and then we're going to go over the test registration instructions. I'm going to pass out the registration forms, and we'll go through them together. Okay? Good? Does anybody need a little break? I know that that last one was long, a lot of content there. How about if we take a quick 5-minute break? Okay. I just won't turn the thing on. Take a quick 5-minute break, stretch your legs, wake up a little before I show you these last 2 skills. Okay. All right. So 62. Oh. Oh. I am so sorry, guys. I forgot to unmute me. Okay, sorry. I know I need a volunteer. I need a helper. I am no good at this by myself. Okay. Oh, here's a question. Okay, hold on. So Helen asked, this is a good question. Helen asks, a nurse asks you to turn and reposition a patient who is assigned to another CNA. Is this okay for you to do? That's a great question. And the answer is we are nursing assistants. So if the nurse is asking us to do a task, it is perfectly okay for us to do that task because we are there to assist the nurse. Whether that patient is assigned to us or not does not matter. If the nurse asks us to do something and we have been trained to do that task, we should help them out. Okay, great question. Mouth care, here we go.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to do mouth care. Is that okay?
Yes.
Okay, I'm going to put the head of your bed up. And then I'll close the curtain, wash my hands, and gather my supplies.
Okay.
We'll get you to a full upright sitting position for safety. And if I can get you to lean forward, please. There you go. Is that more comfortable?
Yes, much.
Okay, I'm going to close your curtain and wash my hands now. I'll gather my supplies. I'm going to start with a barrier, and we'll place that on your overbed table. I'm going to get a towel, a set of gloves, a basin, toothbrush and toothpaste, and a cup of water. We'll prepare the toothbrush first. We'll get it wet, place a little bit of toothpaste on it, and set it in the basin. Mr. Jones, can I place this towel over your chest?
Yes, please.
Okay. And now I'll apply my gloves. Okay, Mr. Jones, can you open wide for me? I'm going to brush the back on the bottom. The back on the top. And can you bring your teeth together? And stick your tongue out for me. Thank you. Set that aside. Go ahead and take a sip. Rinse your mouth. Let me wipe that off for you. Another sip.
No, thank you.
Okay. Now I'm going to dispose of my cup, wrapper, and toothbrush. I'll be right back. I'm going to remove the towel and place it into dirty linen. Going to go clean the basin, and I'll be right back. I'll place the toothpaste in the basin, use the paper towel to open the drawer, and place the basin and toothpaste in the drawer. I'll clean up my work environment and go throw these items away. Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No,
A
thank you.
magazine?
No, thank you.
Okay, your call light is right here. If you should have any needs, let me know. Can I adjust the head of the bed for you?
No, this is great.
Okay, I'm going to open the curtain and go wash my hands. After washing my hands, I'll think about my skill, make any corrections I need to make, and then tell the evaluator my skill is done. Okay. All right, thank you. Any questions on that? Mouth care. This, I think, is one, I used to do this one as the very first skill I would teach because it's something you guys are all familiar with. Everybody knows how to brush teeth. So you're just making accommodations because you're brushing somebody else's. It's not a hard skill. I ended up moving it. Today is the halfway point, by the way. You guys are half done. It goes fast. Goes fast. I moved it to this point because there's so many things I have to tell you in order for you to understand glove rules and barrier and all that. So we're utilizing a lot of principles in this, even though it's not a hard skill. That's why we're doing it at the halfway point instead. All right, last skill for today is respirations. Nothing new to teach you here. We know to follow the care plan. We know to do the opening. We know to evaluate if we need gloves, and we know to do the closing. For this skill, somebody with your level of experience should be able to do it within 5 minutes. You'll be doing it on another testing student who will be laying in bed. It is a documentation skill. Normal respirations are between 12 and 20. So generally speaking, somebody breathes between 12 and 20 times a minute. Breathing should be quiet, even, and not require a lot of effort. So basically, you really shouldn't be able to see somebody breathing unless you're actively looking for it. If you can hear them breathing, that's abnormal. That needs to be reported. If they're very obvious in their breathing, like that's abnormal. It needs to be reported. Breathing is easy, quiet, and even in most cases. 12 to 20 is normal. If somebody breathes less than 12 times a minute, it needs to be reported because that patient may not be getting adequate oxygen. If they breathe more than 20 times a minute, it needs to be reported because that patient may not be oxygenating their tissues well. Okay, good. So nothing new to learn. If you look at the top of the page here at the care plan, you'll see the patient will be laying in bed for skill. Count the patient's respirations for 1 full minute and record your readings. This is what the documentation sheet will look like for the test. You can see it here. You can see it filled out. Keep your finger there. Go to page 168 in your book, and you can see a full size example of the documentation sheet. And you can use these when you're practicing. This is what the documentation sheet will look like. 168. It's what the documentation sheet will look like for the state exam. Good? Questions? Simple. Step-by-step instructions are here, but let's talk a few minutes about some things that we need to know. First of all, we don't want to tell somebody I'm counting your breathing. Ready? Go. When you tell somebody I'm counting your breathing or I'm counting your respirations or something like that, it makes them very aware of their breathing, and now their breathing patterns are altered. So we don't want to tell them I'm counting your breathing. Good? Instead, we're going to say I'm taking your vital signs. It's true. Respirations is part of vital signs. We're not lying to them. we're just being a little vague, taking your vital signs. The other problem with this skill is that, let me show you this. In and out is counted as one. In and out is counted as one. So that's one. But here's the problem. Let's say that this patient here is one that I'm doing respirations on. So I've done my opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm taking your vital signs. Is that okay? Close curtain, wash hands. Now I'm ready to start my skill. How comfortable do you think she is with me not touching her, not talking to her, and staring at her chest? Very uncomfortable. That's going to make the patient anxious. What do you think happens to breathing when we're anxious? It goes faster. So I'm not going to get an accurate reading here. Does that make sense? So we don't want this patient to feel like I'm a creeper. And that's really what they're going to feel like here. So instead, I would hold the wrist with the elbow on the bed, just like I'm taking the pulse. I'm not finding the pulse. I'm holding her hand, guys. That's all I'm doing here. But she thinks I'm taking the pulse. That's going to keep her calm. This is familiar. And that leaves me the ability to be able to measure her breathing. I'm not doing anything here other than distracting her. Good? Good? Okay. So in and out counts as one. Now, that whole thing, in and out, takes a long time. Take a look at this clock here. Okay. And I'm going to breathe in and out. And I want you to see how many seconds it takes me to do that whole thing. Ready? Ready? How long did that take? Yeah, somewhere between 5 and 6 seconds, right? That's a long time. How long does it take you to glance at that clock and glance back at me? Go ahead, glance at the clock and back to me. Not even a second. So if breathing is taking 5, 6, 7 seconds, and it doesn't need to even take you a second to glance at the clock and back, you now know that you can time and watch at the same time. Good? Make sense? So I'm going to look at the clock. I'm going to pick a starting point and I'm going to say start. Now I know normal's between 12 and 20. Normal between 12 and 20. So I look at the clock, I say start, and I watch her chest. In and out. In and out. In and out. I don't need to look at that clock until I'm, like 8, 9, 10. I look at the clock, see where we're at. Oh, geez, we're not even halfway. In and out. In and out. Look at the clock again. I can still see in and out. You can time because you're just glancing and measure at the same time. This is the biggest pain point for students. For some reason, how do I count here and time at the same time? You don't stare at the clock. You stare at the patient and glance at the clock. Got it? We're going to do it as long, hold on one second. There we go. We're going to do it as long as the care plan tells us to. So if our care plan says to count for 1 full minute, how long are we counting for? 1 full minute. If the care plan does not tell us to count for 1 full minute, we can use that same method that we used for pulse, count it for 15 seconds and multiply that by 4 to get our minute. But this care plan for the test tells us to count for 1 full minute. So we're going to count for 1 full minute. We always follow that care plan. Normal is between 12 and 20. Good? Okay, so there is something you can use on the state exam to make this a little bit easier on you. And I'm going to show you this now. I'm going to put her on that table. So can you move those gloves kind of back into the side, in that, where that chair is, you know, just. Oh. She's going to study with you guys.
Yeah.
There you go. There you go. Now your spot is back. Okay, so can I get somebody to come lay down here? Somebody, anybody. As long as you breathe, that's all you need to do. Thank you. Nope, leave them on, just lay down. Get comfy. Okay. Now, when you are counting somebody's breathing, when they're laying down, the best place to look is their upper abdomen, because you can actually see it go up and down. So all they're going to do is breathe, okay? You can see it go up and down, but it's not like really visible. So for the test, remember those evaluators are counting too. And we want those evaluators to stay on the other side of the room. We don't want them hovering. So if you take an alcohol pad and you lay it on the tummy, what does that do to your ability to see the breathing? Makes it easier to see, doesn't it? So that's what we're going to do for the test. We're going to use an alcohol pad on the test to make it easier to see the breathing. Remember, in and out counts as one. And this allows the evaluators to be able to count that breathing from across the room. We're allowed to use this on the test. You're also allowed to use it in a clinical setting. Now, the reason we use an alcohol pad is it's light. It doesn't interfere with breathing at all. If I put something heavy there, it'll interfere with her ability to breathe. But it's also mystical, magical, and medical. Alcohol pads are familiar to patients. They belong in a medical setting. So if I just throw an alcohol pad on her tummy and say, I'm going to need that for later, she'll actually go, okay. No big deal, right? Because they're used to alcohol pads. Make sense? Okay, so I'm going to do this whole skill from beginning to end. Lean forward for me. You don't look comfortable. There you go. Better. Better? A little bit? Better?
Yes.
Okay. All right, so I'm going to do this whole skill. I'm going to simulate hand washing for the sake of time because this is my third skill. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing good.
Fantastic. I need to get your vital signs. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I have clean hands. Okay, I'm just going to lay this here. This is going to take me about a minute. I'll let you know when I'm done, but I will need you to remain quiet during this time, okay? So let me have your wrist. Pick a starting point. When I'm going to count quietly to myself. I want you guys to all count as well, quietly to yourself. And at the end, we'll see if we get the same number. Okay? Ready, set, start. Stop. Thank you very much. Is there anything I can get for you while I'm here?
No,
Are you comfortable?
yes.
Would you like a magazine before I go?
I'm good. Thank you.
Okay, here's your call light. If you need anything at all, just press that red button. I'll be happy to come back and help you. Bed is in the low position. Environment is clean. The patient is covered with clothing. Wash my hands. I'm going to document on the documentation sheet. Wash my hands again, and then tell the evaluator my skill is done. Thank you. You can go ahead. What'd you guys get? Everybody get 18? I got 18. Now for the test, you can be off by 2 breaths in either direction. So if I got 18, if you got 16, 17, 18, 19, or 20, you are accurate. Good. That is the most assigned skill for the state exam. You have a very, very good chance of getting respirations.
Where are the documentation sheets?
They're going to give it to you before you ever start the skill. So you would want to take that form and put it close to you on the overbed table, which will be empty. And they'll also give you a pen. They don't even expect you to have a pen with you. So they will give you the documentation sheet and a pen. You want to put it in a very visible location to remind you at the end to document. Now, what I didn't do is stop counting and go, okay, I got 18. What'd you get? I did not do that because our care plan told us to measure and record. It doesn't say measure and announce. Make sense? So we're not going to tell the evaluators what we got. We're going to write it down. Exactly. If you go into the test with a mindset of they don't even exist in your world and you focus 100% on the patient, you will pass. You will pass. Yeah, you don't even have to say anything for the test. You can just throw one there and you don't have to say anything. In a real life, what I say is exactly what I said. I'm just going to place this here. I need it later. I'll put this here for later. Yeah. And the reason is that most people won't even ask why. And if they do, you give them a very non-committal answer like, yeah, I just need that later. And I don't know why, but people will accept that. Anything else in medicine, they'll ask you a million questions. But for some reason, they just accept it and they're okay. I've never had anybody go beyond, what do you need that for? I just need it for later. Oh, okay.
I said we're not going to be telling them, we're going to tell them we're taking a pulse. Now, if I'm going in to do a full vital sign, isn't that going to look a little weird that I do it twice?
Yes. Now, because in a clinical setting, when you're doing full vital signs, you're going to use a pulse ox to give you the pulse. Okay. The patient doesn't know that, but the pulse ox will take the pulse for you. You'll be doing the respirations.
Is it okay though, even if the doctor said you can use the pulse ox, this is not really the best way, and the patient is wondering why do it, could you just say, just when the doctor wants me to double check it?
Sure. Absolutely. Absolutely. That's a great answer as well. Yeah. I'm going to tell you very, 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 very rarely in your life will you ever count respirations for 1 whole minute. I can't even think of a situation where it would be warranted. Very rarely. But for the test, because that's what the care plan tells us to do, that's what we're going to do. Most of the time, you're going to count the pulse for 15 seconds and the respirations for 15 seconds. Multiply both of those by 4, and there's your reading. So we're only doing something for 30. Good? Make sense? Okay. All right. Oh, I'm only 2 minutes late. Imagine that. Amazing. Okay. You want to take a screenshot of that? Those of you who are joining us at home, take a screenshot. Please remember when you're trying to home, when you're trying to review this, just take one and pass them around for me, if you would. When you're at home and you're trying to remember everything that I'm about to tell you in the next half hour, this is going to be in your wrap-up email. It'll be the last half hour of class 4. Gives you test registration instructions. The last half hour of class 4. So I have detailed test registration instructions on my main website, 4YourCNA.com, under testing. So go to 4YourCNA.com. Oh, take one and pass them around, please. There should be 2 for them too. So you go to 4YourCNA.com, under testing, there's test registration instructions. There's 2 things on this site. When you click this, you're going to see 2 things. One of them is a video. I actually did a registration on the screen and videotaped it. So you can watch me do this entire registration. The next one, because I go kind of fast, it's a video. The next thing below it is a slide-based presentation where I took screenshots of every single step, and you guys know how detailed I can get, right? Every single step, and put it in a slide-based presentation that you guys have control over the timing. So watch the video to get an overview, and then use the slides, whatever the slide has on it, do that step, and then go to the next slide. Do that step, go to the next slide, do that step. You try to keep up with the video, you might get lost. Video gives an overview. Slide-based gives details. Good? Questions? All right, so this is our roadmap. This is what I just handed out to you. This is our roadmap. There's 4 steps to this process. Step 1 is the first column. It has a 1 on it. We're going to get a background check. I'm going to go through each of these individually, but let's go over an overview first. 1 is get the background check. 2 to 3 days after you do your background check, step 2 tells us to apply for the test. Within 1 to 3 days of applying for the test, you're going to get an email from Prometric. Open the attachment. In about, usually about 10 to 14 days after that first email from Prometric, you're going to get another email from Prometric. Open the attachment. So up here tells you the number of the steps. In between tells you about how long in between steps. And then this is the particulars you need to accomplish those steps. You guys understand this blueprint?
I have a quick question. Like for my job that I have, they had to do a background check already. I had to pay for it. Would they be able to see that?
I have no idea,
Okay.
and neither will you. So here, let's get into the background check so I can explain what I mean, okay? Everything that I'm going to be talking about is going to refer back to Prometric's website, which is this. It's prometric.com/nurseaid/FL. That's on your sheet here, okay? In column 1, you've got that website. Remember, I take all the notes for you. In step 2, you've got that website on step 2. So here's the thing. In order to approve you for testing, this process is not as straightforward as it seems. I mean, this makes it look pretty simple, right? And from your standpoint, it is. There's only 4 steps here. Super easy. But on the test administration side, it's way more complex than this. So I've got to explain this to you. When you register when you get your background check, it is a level 2 photo-enabled background check for medical. That goes into a very specific filing cabinet. If you get a background check done for concealed weapon, foster care, school board, bank, doesn't go into this filing cabinet. Those are different filing cabinets. we need your background check to go into this filing cabinet. And I'm actually going to give you a code that's on this form that makes sure your background check goes into the right filing cabinet. When you apply for the test, that application goes to Prometric. Prometric gets your application and goes to that one filing cabinet, and they pull your background check. If your background check is not in that filing cabinet, everything stops. Okay? So you apply for the test, Prometric goes to the filing cabinet and pulls your background check. They put your background check and your application together, process your payment, and then ship that whole packet off to the Board of Nursing. The Board of Nursing looks at your background check and your application, and they clear you for testing. This is not an automated process. This is a human hands-on process, because they have to make sure that somebody doesn't slip through the cracks who's a crazy axe murderer and is going to murder Martha in her bed. This is a human process. So it takes a little bit of time for the Board of Nursing to look at all of the applications that come in and make sure that you are not the Texas Chainsaw Massacre. Good? Make sense? When the Board of Nursing says, oh yes, that person is fine, they send that back to the Board of Nursing. I'm sorry, back to the Board of Nursing sends that back to Prometric, and Prometric says, cool, this person is okay to test. You are going to get an email that says you have been approved for testing. That doesn't give you your test date yet. It just says, hey, we heard back from the Board of Nursing, you're approved, you're good. A couple of days after that, you will get your test date. Do you guys see how complex this system is? And how there's a lot of moving parts to this and a lot of agencies? This can be thrown off by weather. If we have a freak snowstorm and Tallahassee is under 6 feet of snow, people in Florida don't do well in snow, that whole system just kind of stops. So it can be affected by weather. It can be affected by the Postal Service. If the Postal Service goes on strike or a mail truck falls off the road or something, that can affect this. So understand that this is not a quick, I applied, why don't I have my test date yet process. It can take a little bit of time. I'm going to give you guidelines on time in just a few minutes. Does everybody understand that?
So they have to give you a test, and then you can't set like
No, you don't get to say. I'll tell you what to do in just a second. I'm going to go over that. I got to sit, guys. I'm sorry. I'm hurting. Okay. All right. So everybody understand the process here. So the first thing we have to do is make an appointment for a background check. Step one. If you already have one or you think you have one, you can skip step one. You can skip it. The problem is, remember the order there? You apply, they go to the filing cabinet, assuming your background check is there. If they go to the cabinet and there is no background check for you, they have to send you a note that says, hey, we don't have a background check. And you have to go get one. They don't go back to that filing cabinet immediately. There's nothing that says, hey, Lisa's background check is in now. It's whenever they get around to it. So if you don't have a background check on file, if you think you do, but you don't, it's going to delay your test processing. Good? Make sense? Now, if you're 100% sure, hey, I just had one done. It was a photo. I, signed the little screen thing. I know it was for medical. I'm good. That's fine. But there's no way for you to check. Make sense? There's no one for you to call. Now, if you have your own background check, because some people go get their background checks done like I don't know why, but if you go to the sheriff's department and you get a background check done, right, and you physically have one, they can't accept it because it's been in your possession, and Photoshop can take any criminal background and make it clean. And I've got some Photoshop skills, right? I mean, look at all the graphics I do. They know that, guys. So this has to do with chain of custody. So my suggestion is if you aren't 100% sure, go get your background check done. You need it to work anyway.
So you did a background check, so make it come to a background check. Then you fill out the form in this packet?
We're going to go through that step by step. Yep. But does everybody understand about the background check?
So if you're not for sure, just go ahead and do it.
Yes, that is.
I think I may because of my job, but I don't know if it's the same background check that they would be using. It is a medical background check, and I know that, but I don't know.
If it's the right one.
Yes.
Yeah. My advice to everybody that goes through my class is just go ahead and get a clean, new background check because you need it for work. Nobody can hire you if you don't have it. And if you get it done for certification, it's guaranteed to be in the right place for the job because they access it and through the same route. Good. Does that make sense? Background checks are only good for 5 years. I actually need to get a new one. I'm due for renewal on my my RN license this year. In fact, next month, I got to do my continuing ed. Oh my gosh. So yeah, I'm going to have to go get a background check done because they're only good for 5 years. So keep that in mind. You have to do it periodically. So you may see me at the background check place. Just wave. All right. So everybody understand the process. I just need you to understand the process. And now we're going to go through the particulars. Okay. All right. So where do you go get a background check done? If you go under candidate resources on Prometric's website, under candidate resources, toward the bottom, you're going to see a link that says FLDOH fingerprint vendor list. When you click on that, it takes you to a website done by the Florida Department of Health that lists all of the fingerprint vendors. And it's done by county. I'm going to tell you that the majority of the ones on that list are not who you want to use because a lot of them are mobile and they charge you like $150. Or they don't do photo enabled. So you've got to be really, really careful about who you're using for your medical background check for licensing. Back in December, I had a class that one of the students said, you know, you can get it done at the sheriff's department. And I said, well, yeah, a couple years ago, a couple students tried to do that and they seemed to run into some processing problems with their test. And that class decided to try, most of them, the sheriff's department. I called up the sheriff's department. Can you do it for CNA testing? Yes, 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 you can do it. I said, do you have the photo enabled? Yes, yes, yes. They went to the sheriff's department. Every one of them had test delays. In fact, I have a couple of people that graduated in December that still have not tested. So does the sheriff's office do it? Yes. But I know that if you go through one of the two I'm going to show you, it's a whole lot quicker. You will get testing quicker. So take that for whatever it's worth, okay? The one that I recommend in our community is Deontis, which you can see in that first column, the first link, Deontis. When you go onto Deontis's website, you have to create an account. When you create an account, it's going to send you an email to verify. You click on the email, you go back to the website, you enter your information in, and then remember the last half hour of class 4, because you're going to want to go back and review this. When it takes you, when you get into Deontis, if you don't have these instructions, you will be all kinds of confused. Good. Everybody get this? Okay. When you go on to Deontis and you get signed in, you're going to see that this is it. This is all that. This is what you see. And if you don't know which one of those to do, you get like stuck. You want to do Florida services, not double check, Florida services. When you click on Florida services, you need an an ORI code. Our ORI code is highlighted in that first column. It's highlighted. Our ORI code is EDOH0380Z. That's our ORI code. That tells them which filing cabinet, that's the name of the filing cabinet. Tells them which filing cabinet you want these results to go to. So you're going to put that ORI code in there. When you get the ORI code, it's going to tell you, hey, that ORI code is for CNA by exam. Is that the one you wanted? And you're going to say yes. So you confirm. Then you get this, and this is where everything breaks down. Okay, I got my ORI code in, I'm good. What do I put here? Reason for request. You want other employment or licensing. When you click on other employment or licensing, right below it is going to ask for an OCA number. We don't have one. We're going to skip that. Then everything gets easier. You just put your name, your address, your sex, your, social security, all the stuff they need to know about you. Make sure it matches your photo ID, by the way. And then once you get all of that in, it's going to ask you, where do you want this background check to happen? Our closest testing center or background check center is on Barclay and Spring Hill Drive at the UPS store. Barclay and Spring Hill Drive. And they do same day appointments. So if you register like today, you could probably get in at like 2 or 3 o'clock to do your background check. So you're going to select where you want to do the background check. You're going to select the date that you want the appointment. And then you're going to select the time. It'll come up with what time do you want your appointment. Once you've selected all that, it's going to give you a checkout page. Now, right now, as of the time I did this, which was, I think November was the last time I updated this, the cost was $76.68. I don't know if that's still valid. Don't yell at me if they went up in price. Eggs went up in price. Everything went up in price. But as of the time I did this, it was $76.68. You're going to enter your credit card number. They're going to email you an appointment confirmation, and then you just go to the appointment. They take a photo, they take fingerprints, and a signature. They aren't going to give you anything. You're just going to go to the appointment, do what they ask you to do, and then go home. They don't give you anything. You don't mail anything in. You just go to the appointment. Everything's electronic. After you've gone to the appointment, wait about 24 hours, and then we're going to apply for the test. Now, what I gave you, this packet, if you go a couple sheets in, is the actual registration form. This is it. It's the same thing that's online. But if you go back 2 pages, if you see this, right, go back a page. These are all the test locations in Florida. Now, I separated these by region. It's presented a little different than Prometric presents it because I made it make sense. I organized it by region for you. If you look at the very bottom of the Central Florida region, which is where we are, very bottom one on the first page, it says CNA TAMAIR. Very bottom of the first page. That is our closest testing center. That is off of Waters Avenue down by the airport, basically right off of the Parkway. There is another testing center in Tampa over by the mall, like Busch Gardens area. And then there's another one in Temple Terrace, which is way over by like 275. So, or 75, I'm sorry, way over by 75. So, you've got a couple of options, but Agilus seems to be our closest one. You can decide where you want to go test. If you want to go test in Miami and jump on a cruise ship afterwards, go for it. Register for a test in Miami. Nobody cares. The test is the same everywhere. Now, we're not going to go through every single line of this application, but there are a couple things that I do need to bring to your attention. You can mail this packet in. This second right here, second column, has the address to mail the packet in if you want to fill it out by hand and mail it in. Takes longer to process that way. Or you can take the online application is this exact application. It looks just like this, just online. Oh, really? Really? Nice. Good. Nice. So they saved you 10 cents. Go spend it on eggs. All right. So that's the address. If you want to mail in this packet, I suggest that you do the online registration because it does seem to be processed quicker. There is contact information for Prometric. If you have a problem with this application process, you have to contact Prometric. They're not the easiest people to deal with. Be persistent. Ask for a supervisor. They are not the easiest. The people that answer the phone at Prometric are minimum wage employees, and their entire training is this: get them to hang up. Get them to hang up. That is their training. Get them to hang up. So they're going to give you stupid answers that don't help you a bit to try to get you to hang up. So your answer, I'm going to give you very specific answers that you need to give them, but you need to ask for a supervisor because the supervisor is the only one that can look at your account. Okay. If you, on the very, very back, let's go back here. Back here where it says page 6 on the bottom, it tells us on the very bottom, if you do not receive your emailed ATT letter, that's your authorization to test, that's your test date letter, within 10 to 14 days of receipt. So basically, they get your application. If you don't get your test date within 10 to 14 days, what does it tell you to do? Call them. Absolutely. When you call them, that person that answers the phone is going to tell you it can take up to 90 days to clear you for testing. What does your application say? 10 to 14 days. This is your contract with them, and that's what you're going to use to get a supervisor on the phone. Good? Remember, their whole training is get them to hang up. Okay, so really quickly, the online application form is on Prometric's website, just above the paper application form that I printed out for you. When you go online, you have to create a account with a super secret password and all of that, and then it's going to bring you to the application. It says, please make sure your name is truly your name because you have to have 2 forms of ID when you test, and they have to match. Below that is going to be, do you need ADA accommodations? Do you need a seeing eye dog, a sign language interpreter, something like that? And then we get to the actual application. This part you can fill out on your own. You know your name, your address, your phone number. You can fill all of those demographics up by yourself. We're not getting involved in that, but go to page 2 because this will really mess you up. I know I got 3 minutes, guys. Bear with me. If you have a felony in your background, you need to see me after class, and I will help you with this section. If you have no felonies in your background, for number 1, check no at the bottom of page 2. If you have no felonies, for number 1, check no, where it says criminal and Medicare, Medicaid, Medicare fraud questionnaire. If you have no felonies, for number 1, check no. Do not check off A, B, C, D, or E. Just no. If you have no felonies, check no for number 2. Do not check off A, B, C, D. Go to the next page. For number 3, 4, and 5. Listen closely. If you worked for a doctor who was committing Medicaid or Medicare fraud, and you were taken to court and told that you cannot work in medicine ever again, see me after class. If that does not apply to you, then check no for 3, 4, and 5. And yes, we had 2 doctors in this community that happened to. So I have to go over this.
So if you're not the doctor that did it, why would you be punished?
Again, they have to you'd have to go to court. They'd prove intent, right? But you now have all of the means necessary and the knowledge to be able to defraud the government. We don't want you to have access. But they have to go through an entire process to strip that right away from you. This isn't something that would be done without your knowledge. But yes, if you know how, you'll probably use it again. All right. So now we're on page 3. Disciplinary history. This has to do with, have you ever been a medical professional in Florida or any other state, knocked around some old people, got your license taken away, and you want to do it here? That's what they're asking. So you can read those questions and answer them. At the bottom of the page is criminal history. You either have one or you don't. You can answer that on your own as well. So this brings us to page 4. I cannot help you with page 4. And page 4 is actually becoming way more important than it used to be. Healthcare is stressful. If you do not have good stress coping mechanisms, it may impact your ability to work in healthcare. And they're trying to identify these now. If you have a substance abuse disorder or a serious mental health issue, you may be encouraged to find other areas of employment. So fill out page 4 on your own. Now, page 5. I've already filled some of that out for you. Page 5, all of you must register as an E3 challenger. Do not register E1 or E2. If you register E4, they're going to require additional documentation.
What if you had that?
If you're lapsed, like you've had a CNA in the past and you're lapsed, E5. E5 is lapsed. Yeah, you can just, E3 is fine too. E3 covers everything. E3 is good. Leave it. But if you're lapsed, you can check E5 if you want to. Nobody really cares. It's E1 or E2 that's going to mess you up. E4 will require other documentation too. But please don't check E1 or E2. I can't help you. Down below that is training information. I've already wiped that out for you. Do not answer training information. It's only if you answer E1 or E2. Did we answer E1 or E2? No, it does not apply to us. So now we're down to test site information. Remember the list of available test sites. You want to figure out where you want to test. This is a change from the paper application if you do it online. Online is going to be a drop-down box. Check a Gillis. So you have to know where you want to test to be able to figure out online which one to select. Good? Down below that, it's going to ask what kind of exam do you want to take. The normal exam is the first one, the plain Jane exam. Oops. Let me go. Where is it? Plain Jane exam. Most first-time testers are going to test the very first option there. If you want the computer to read the written test questions to you, if you've got ADHD, Dyslexia, reading disability, you might want the computer to read the test question to you, especially if English is not your first language. Other than that, select test one, first one. You can take the written test in Spanish if you want to. For anybody that would qualify for. If you have to retest for whatever reason, if you have to retest, if you fail one part, you only have to take the part you failed. So if you failed the skills and passed the written, you would retake the skills. The bottom part is for that. That's for retesters. Okay. Total cost of the test is $155. Page 6 has you check a box that says you have received these two pages that are at the very back. You can now check the box on page 6 that says you've received these two pages. You're going to read the affidavit and sign the application. Online, you would sign it electronically. All right, there's one more change in the online application we have to talk about. In the online application at the very bottom, it's going to ask you how you plan on submitting supporting documentation. So if they send you an email that says, hey, we need more information about that criminal history you have, and you've got to send them stuff, how do you plan on doing that? There's going to be two choices, by mail or by fax. I don't care which one you check. They don't care which one you check, but the application will not be processed unless you check something. So check a box. Chances are you'll never have to send anything in, but check a box. Then you get down to the very bottom and you're going to have two choices. You can either save or you can submit. If you save, most people like to save before they submit. If you save it, all of your payment information goes away and you have to re-enter it before you submit it. Okay? All your payment information goes away. So fill it out, save it, put your payment information in, and then submit it. Good? Crash course on CNA test registration. I suggest that you register for the test now. Get your background check done. If you're financially able to, register for the test. That way you're testing a week or so after graduation. It's perfect timing. If you do that, if you register for the test this weekend, if you run into any problems when you come in on Monday, I'll be happy to help you. If you wait until after graduation to register, it's harder to reach me. Okay? So register for the test. Have a great weekend. Do something fun. Do something fun. Chapters 5 and 6 for homework. What's that? Oh, yeah, I'm sorry. Thank you. Thank you. Worksheets. Grab a worksheet on your way out. Grab a worksheet. See, Jake's not here. I'm all messed up. We need him. He needs to come back. All right. I will see you guys in class on Monday. Have a fantastic weekend. Those of you that are attending virtually, thank you so much for tuning in. And we hope to see you on Monday.